It's my pleasure to start this morning's first session. Today is the third day of the Taipei Valve Summit program, and we are happy to start this session because it is a very interesting session, and I think it's a very new one because the procedure we mentioned in this session is totally new to somebody. As we know, to seek a catheter-based or minimal invasive approach to treat disease is the nature of human beings. And with the use of catheter and some minimal invasive approach to treat structure, especially the valvular heart disease, maybe it's the way to go for many unmet needs. So in this session, we will discuss about the leaflet modification, unicorn procedure, BASILICA procedure, and LAMPOON procedure. Firstly, I would like to start with leaflet modification in valve procedure. This talk will be delivered by Dr. Bapat. Is Dr. Bapat online?
It gives me a great pleasure to present on the topic of leaflet modification.
Yes. Good to see you again. Can you show us your slide? Okay, thank you very much.
Since we have a meeting in New York, I could not join you in person. Hopefully next year I'll make it to the Taipei Valve meeting.
Thank you.
These are my disclosures. So let me start by saying that for the aortic valve in valve, coronary obstruction has been one of the major and life-threatening issues. Although it happens in less than 2% of cases, it's pretty important that we plan for these patients before and do something to mitigate the issue if patients are not fit for surgery. Similarly, for the mitral procedures, which is valve in ring, or valve in mag, and even in TMVR, LVOT obstruction presents as the main Achilles heel. LVOT obstruction can be predicted to a point, but in many patients, it can surprise you on the table. In these patients, leaflet modification becomes an important supplement to prevent these life-threatening complications. This all started with LAMPOON, which is for mitral valve, then slowly progressed to BASILICA for the aortic valve. Interestingly, it's not just for prosthetic valve, but also can be used for native valves such as type 1 or type 0 bicuspid valves. Dedicated devices now are being developed, such as shortcut telltale guide wire, which helps you to do the procedure slightly easier. And there are many other technologies on its way. So let's start with a more common procedure, although it was the second procedure which was introduced, so-called electrosurgery. Valve in aortic position, as I mentioned earlier, coronary obstruction becomes a life-threatening issue. This is more common when the sinuses are narrow, and also common when design of the valve is such that the leaflets are outside in a stented valve or in stentless valves. And hence, as we know, with mitral flow, trifecta, and stentless designs, this can be a big issue. So a leaflet tear can technically mitigate this issue to a point. And in these figures, as published by Dr. Jafar Khan, you can see a mitral flow which has been cut right in the middle. Once you implant the sapien or evolute R, there is a flare of that cut causing and allowing flow through the empty cells. This is a very nice animation. This is a mitral flow or a trifecta design. There are guide wires outside the leaflet and a snare in the LVOT. You catch the guide wire, electrify it, and then cut the leaflet. Now, of course, there may be many limitations, such as how much flare does the valve cause, and hence this group went ahead and did what is called as a balloon-assisted BASILICA to allow the V to flare, not short, but quite long way. This is just one of our cases. This essentially shows you the setup and walks through the steps. Here we have you need two arterial accesses, right femoral artery access. We use gold dry seal, so you can pass multiple catheters through that. By the left femoral artery is the 7 French, and left femoral vein is 8 French. Aortic valve is crossed, as you can see here, through the dry seal. Once it's crossed, a V18 wire is advanced into the left ventricle. You can see it in the picture there, the V18 wire. The next step is a 6 French multi-purpose art catheter in the LV over the V18 to stabilize it. Following that, aortic valve is crossed second time again through the gold dry seal in the usual manner. And a 5 French pigtail is put in case we do basilica and there is a problem, you can easily exchange it with a safari wire and then deploy the valve. A gooseneck snare is advanced alongside the V18 wire into the LVOT, and this is what you can see very well in this picture. So this is how it looks like when we are doing the procedure. You have got a 7 French air 2, which is going to sit on top of the leaflet. And then you have what is inside that is the 5 French Lima catheter. You can see the JR4 guide with a snare in the LVOT and the V18 wire stabilizing the whole contraption. Echo and fluoroscopy is used to identify and make sure that you are in front of the coronary artery. This is very important, especially if the previous indication for AVR was a bicuspid valve. In these cases, coronary may be slightly eccentric. Leaflet is then traversed by advancing a Stato 30 wire. You can get the details of all the setup in a variety of publications and over a microcatheter, and then electricity is applied at the back end of the wire. And here, as seen in the animation, you can see the direction of the puncture has to be towards the LVOT. Once this is achieved, wire is snared in the left ventricle, as you can see very nicely here. You can also see at the back end of the table, the two operators are very engaged in doing the procedure. So it's definitely a two-operator procedure, if not three. A flying V is made. Essentially, the principle of flying V is you denude the wire and make a small bend in it. And you denude the wire only on the inner surface of the wire, of the V, so that there is electrical isolation in the rest of the wire, except at that point of flying V. So all the electricity, once you give it at the back end of the wire, is concentrated at that point, which allows you to cut the leaflet very easily. Again, I've cited a publication by Dr. Liederman, and this gives you further details on how to do it. This is exactly what I was mentioning before. By isolating only the inner part of the V, the electricity is heavily concentrated at that point. And by infusing dextrose at the same point, this allows localization of the heat for that 1 or 2 seconds to cut the leaflet. This setup may look very complicated, and it is indeed complicated, and that's the reason why dedicated devices are being now done, and these devices will achieve similar thing, hopefully, and reduce the number of people and the contraption needed. Once you do the flying V, essentially, when you are ready, both the catheters are held taut, and then when the electricity is applied, as you will see it here, the catheters are pulled, and that achieves the leaflet cut. And you're going to see that in any minute now, what happens when the catheter is cut. The laceration now is performed by applying electrocautery to the stato wire and injecting D5 or dextrose and pulling both the catheters. And this is what you will see now. The setup is ready. First operator is pulling both the wires, and it really is very easy. And at that point, you stop applying the electricity and retrieve the catheters. As mentioned here, at least 2, if not 3 people are required to perform this procedure. Once the laceration is done, one is to inject the dextrose, and other to just apply electrocautery. Then the safari wire is put through the pigtail. You have the 5-inch pigtail. And once you do that, then you proceed with your valve-in-valve procedure as shown here. In this particular patient, the VTC distance, that is valve to coronary distance, was only 1 millimeter. And it was important to do basilica for the left. Echo shows normal flow into the left main. And aortogram will show normally filling coronary artery, as seen here, the left coronary artery. Lampoon, as I mentioned earlier, was the main technique which started, and essentially this was to cut the anterior mitral leaflet at A2 right in the middle, and to achieve a similar V, which is of course more in the mitral because it's a longer leaflet and there is a lot of space. The idea was to expose the non-covered cells of sapien to allow the flow in LVOT. This was presented and published in 2016 by Jafar Khan. Here, a beautiful animal experiment shows what happens. Essentially, you apply similar electric principle by puncturing the anterior mitral leaflet in the middle, or initially as they started without puncturing, that is through aorta and through the LA, and then forming a V to cut the A2. And this is how it achieves the flare after cutting the leaflet. This is one of just an examples to show you a case of ours where we have done a lampoon in a band, followed by a sapien valve with no LVOT obstruction. Now you will appreciate in the figure D that if we hadn't done that, this would have led to a obstruction for sure, as the sapien is touching the ventricular septum. There are many types of lampoons. For making it simple, there's a retrograde lampoon, antigrade lampoon, there's a balloon augmented lampoon, and a tip to base lampoon. The details of each of this can be easily found now in literature. Each has an advantage and an indication. Most of the people now prefer antigrade lampoon. However, even retrograde lampoon has been performed regularly. So coming to the last part of this presentation, dedicated devices. The first dedicated device is rather a shortcut device. As you can see, this is a 14 to 16 French catheter, which is passed over a guide wire. There is a stretch segment in the aorta, which allows you to precisely position the device in the center. A cutting arm is then opened and then is positioned on top of the leaflet. The procedure is fluoro and echo guided. However, this can be entirely done under fluoroscopy. As you can see here, very nicely, this is positioned right at the base of the valve, which is very important. The splitting element, which is like a knife, is activated, and then the device is pulled up. The IDE study for this device is now completed and is waiting approval in the United States. More than 60 or 70 cases done already with good safety record. The device is slightly bulky, and the cutting mechanism may or may not cut through the calcium. There have been incidences of leaflet tear, and hence the second generation device, which is very elegant, is going to hit the market soon. There are many other technologies. Telltale guide wire by transmural system, for example. As I showed you the setup required for Basilica and Lampoon, it can be quite daunting. while the telltale guide wire and some dedicated catheters can help you to do these procedures without much complicated setup. And finally, there is a lot of effort towards leaflet excision. Leaflet excision, of course, will require much more a complicated delivery catheter system, but will also require a temporary valve. However, leaflet excision will be probably a gold standard in terms of doing a redo valve procedures. Now, whether we need it or not, the time will show. As I said, coronary obstruction happens only in less than 2% of cases after valve in valve. So maybe this is too far for an aortic valve in valve. However, LVOT obstruction in the mitral is a much bigger issue for TMVR technologies. And maybe leaflet excision or more robust modification will be achieved by upcoming technologies. In summary, BASILICA and LAMPOON are the most physiological approaches to prevent coronary as well as LVOT obstruction respectively. Reasonable, or I would say now good clinical outcomes. There is a learning curve involved. So if you do more, it's easier. Left side is easier than the right coronary artery lampoon. And dedicated devices will, of course, simplify the procedure. Thank you very much.
Thank you, Dr. Bapat. Maybe we can finish all the lecture and then we do discussion. And the second talk will be delivered by Dr. Simon Lam from St. Mary, Hong Kong. His topic will be unicorn procedure during TEER.
Thank you very much. So my topic is about unicorn. It's about using radiofrequency needle to assist leaflet modification. And we know BASILICA is a well-known technique, and there are also other techniques like trimming stenting. And so it really depends on the local experience, which is the best setting to save patients, and it's about a procedure. But and we know it is promising, but it's too complicated. And you need a lot of setups, you need to make a loop, and you need to snare. And we have dedicated device upcoming that could help, but it's not widely available at this point. So we work on bench testing and try to see if we can figure out a better solution. And the unicorn is one of the examples that we could implement in our patient to decrease coronary obstruction risk. And the concept can be extrapolated to like mitral valve, because we also do mitral unicorn. And I think it works well if the patient's cohort are carefully selected. So we know leaflet level, we can do BASILICA, we can do balloon assist BASILICA, which means after you puncture the pass-through needle, you want to make the best out of it. You want to have better opening of the leaflet, laceration. So balloon assist BASILICA is one of the thing that we could, that actually this concept is also incorporated into the unicorn's technique. So the full name is undermining iatrogenic coronary obstruction with radiofrequency needle. But we also combine with like coronary protection and do trimming stenting, socket stenting as required. So this, we can do things in combination. So we know for usual technique, we have to make sure the puncture site is at the base, at the center of the leaflets. And then once you puncture here, you want to have the best split of the leaflets or function to obtain the maximum desirable like opening of the ostium. So it really had to be quite demanding. And usually the way to do it is just a stato wire and connect to an electrosurgery generator. So why not use what is actually available on hand? So this is the transeptal puncture needle that we use. And for day-in, day-out purpose, is a wire that after going through the septum, it will turn and make a loop. And the versicross system is one of the example. So this is a specification. If you do mitral procedures through LAO, there would be something, it would be useful. And we have two types of wire that's available. One is the pectoral wire, and another is straight tube. Both have its advantage, so we can go to that later. And so the potential benefit of using dedicated wire, first of all, the setup is more clean and easy. And secondly, we did from study, like during the transeptal puncture, for the passing through the septum, you need a slightly lower temperature to go through and less charring of the tissues around. And the puncture site is smaller, but it's very precise. So this is why we think, especially for the leaflet is moving, and you want to have exact, precise puncture point, that would be useful. So potential would be using the unicorn. So step one is setup. We have the usual setup for TAVI with sentinel protection. In the bench testing, we don't have embolization tissues, but I think it's a routine for us to do TAVI even without the unicorn. We'll do sentinel, but I think good to put in if you do something more complicated. And coronary wire protection is still we routinely implement in case we really think this patient has a coronary risk. So there's no additional setup. You only have the sentinel on the right radial artery, and the TAVI access is as usual. So you just go through the same access, modify the leaflet, and immediately you go through with the deployment. And the good thing is there's no time lag between laceration of tissue and deployment of valve. So there's no hemodynamic collapse at all. So we'll show you how it is done. So we need an AL2, usually will be the good catheter, for example, to go to the left side. You need to point towards the base and the middle part of the septum, of the leaflet. And we usually use a smaller catheter like the Navi Cross. To make sure the length matches, you can have different combinations. But the important thing is to be enough to have a 0.035 lumen for the wrist cross wire to pass through. So second step is to advance the transverse catheter, and we use the and position to make sure you echocardiogram 3D. You can see also if orthogonal view and X-ray, you know actually you're pointing to the correct spot. And then you will transfer. You use radio frequency. Just press the button, and then the leaflet will be transversed very easily. The fact that using instead of a very hard needle is a wire that makes it very safe, because once you pass through, you can titrate, or you can titrate the energy to facilitate it. Because sometimes when you encounter very tough leaflets, wrist calcified leaflets, that helps. Secondly, once it passes through the leaflet, it becomes a J-tube or become a pigtail wire. So when it's advancing to the left ventricle, it's no trauma at all, and it's very safe for additional maneuver. Next would be exchange to a 0.014 coronary wire to use an NC balloon for coronary arteries, like the NC Euphora, for example, and then usually 3.0 or 4.0. This is the first step. If you have a balloon that is able to go through a 0.035 wire, then it's perfect. But usually we need to change back to the coronary wire for this purpose. And then we go for a sulfurary wire after the ballooning. And then the second step would be the balloon, using a peripheral balloon. It's a bigger balloon, like 10 millimeter to 40 millimeter, but it's just enough for the nose cone of the diaphragm system to pass through. And then you deploy the valve, and then you check the coronaries. So just to illustrate one case, this is a patient in stage renal failure. Somehow have very early degeneration after the SAPIEN valve put in 3 years ago. And you can see that because of the calcium, after deployment, it had a very good result, but it pushed to the other side. So it pushed literally to the left coronary cups, and the VTC is 0 in this case. And it's bioprosthetic failure with stenosis. Certainly, we will check any thrombus, any other issues that we can solve using a non-invasive way, but there's no. Mainly likely because end-stage renal failure, the calcification process. And so we have to treat this patient. But the problem is there's low-lying coronary ostium. The sinus of Valsalva is effaced. The virtual valve to coronary distance is 0 millimeter. And if you expand S3, that usually you have additional outward push. So this is the first step, is the transversal of the leaflets. So this is a protection. We have a guiding here. You can see the catheter is pointing towards the base of the leaflets, and you will do orthogonal view to make sure it is in the middle, also at the very at the very basal area. And so this is high transverse. You just press the button, and you can see the wire actually will go through. So it's very precise. I'll just go through because it's turned to be a J-tube, and it's very safe. So our original concept, we try to use the loop, the pigtail loop, the kind of bigger curve, but it's a little bit difficult to control when you go through the catheter because of the intrinsic curvature and stiffness. So the puncture size sometimes is difficult to control, but if a J-tube is more easy. So second, we call S1, this step one, after the transversal, is to use a coronary balloon, usually 3.0 or 4.0, and just to open up a little bit in lumen. So because just you're making a very small hole in the leaflet, there's nothing affecting the hemodynamics. And the next step is S2 is to go through using a bigger balloon. Usually it's a peripheral balloon. 10 millimeter is good enough, but we have bench testing for different valves. They require slightly differently for both fine pericardium and porcine valve. But the step 2 is to use the peripheral balloon. So what about the third step? So we call S3, it's just to implant the S3 inside that hole. And you can see, because we have the peripheral balloon to prepare the hole so the Lowe's cone can go through, you can see we expand very slowly, and up to one point, there's certain giveaway. So the leaflets are immediately pushed to the other side. There's no time for the tissue to go away. And we can check the coronary afterwards. You can see there's absolutely no leaflets over there. It's not just a cut to spread it, but the leaflets are all pushed to the other side. And the left main is safe now. So just a bench testing what we do, if we just not do nothing, and with the patient with 0 millimeter VTC, then this actually creates, a new skirt will create a wall. And you can split it by BASILICA. I think it also works well in this case, but we totally avulse the leaflets in this. We're using the kind of modified balloon BASILICA to a point that is a unicorn technique. The good thing is there's no time for hemodynamic collapse. So we do a bench testing on different valves, and you can see this is a E-fluid valve. You can see we try, but make sure it actually works well and bench test before putting human. And this is one example that last year we had a Electrosurgery classroom, and we do a lot of bench like this one. So this is how the leaflet is during the final step. So you can see this balloon, this is the deployment balloon for the sapien. And you can see when it expands, so the leaflet is not totally avulsed after the second balloon, but after this one, it will expand, and you have a very controlled laceration over the left side, and the leaflets are pushed to the other side. So first of all, it's good because the puncture point using a radiofrequency needle, I think it's more controlled. You have experience with the puncture of a septum, then I think this to some point can incorporate into our practice. So there's no need to snare in the LV, less energy needed, and you can direct implant at the valve at the same time. There's nothing worry about potential severe AR that develops after laceration. And we also do that this is a kind of mitral valve in ring procedure. If there's a patient with long anterior mitral leaflets, puncture obstruction, there's also one potential application of this unicorn technique. And also for patients with valve in valve, I think sometimes the leaflets for valve in mitral, they're very slippery. So that you do a firing, I think will work well. We learn from Jian'an that firing U is actually very efficient, but sometimes when they're slippery, they go to the commissures. So this is one potential application. We can see from the 3D TEE that it goes through the basal area, exact site of puncture, and we do the same using a balloon, coronary balloon, and then followed by a peripheral balloon, and then you can create this hole here, and there's no time for hemodynamic collapse, but you correctly deploy the sapien, and then result are very good. So this is how we want to achieve. So luckily, after we tried a lot of bench testing with other valuable advices from different experts, and it had been implemented worldwide just using the unicorn technique. There's slight variations, but even in the New York valve, they're showing cases of unicorn. I think this is something that is the next step we can try to streamline our electrophysiology management. So, but then there are some potential limitation for this technique. So, although it looks very good from the first of all, there's only sapien friendly. So you only be able to do it with sapien. You cannot use a self-expanding valve in that hole. And secondly, there's only allowed one coronary artery ostium to be at risk because all the tissues are pushed to the other side, and you don't want to create, if they're both at risk, then you should go back to the BASILICA, which is actually a very good technique. You have a dedicated device like shortcut. So don't, because it looks good, then you do it, because there are a lot of limitations. But then it's a good thing to put in this toolbox. I think it's also a good platform, like in Taipei Valve, we can, like in this very good electrosurgery session, so how we could improve different techniques to achieve the best patient's outcome. And this is the last. I would like to thank Professor Yin, also give a lot of valuable experience. We have the electrosurgery classroom. We learn a lot from the mitral electrosurgery. And the other thing is we cannot work alone, but it's always good to share experience. And secondly, the team that I work in, electrosurgery team, actually Dr. I-Chen is inventing this device, the design of the unicorn, but we need to go for lots of branch testing before we can like really put in human and try to promote this therapy. So thank you very much for your kind attention.
Thank you, Simon. Excellent talk. Okay, the next talk will be delivered by Dr. Poon from Australia. I think he's also an expert in this field. His topic will be BASILICA, tips and tricks.
Good morning. Thank you, Professor Yin, for your kind introduction. And it's a bit hard to follow something that's already a bit more advanced than BASILICA from Simon, but I'll just focus on the tips and tricks, otherwise it will be a bit repetitive from what Vinny has already talked about. So these are my disclosures. So coronary occlusion still happens. Even now, you look at this Spanish registry over the past decade, the incidence is still there, even though it's less than 1%. It hasn't changed in the past 10 years. Despite all our prediction algorithm, it still happens, whether it's native TAVI or valve-in-valve TAVI. And when it does happen, the outcome is very poor, even if you can stent it successfully. So what sort of prediction algorithm do we have? We've had this from Ribera for many years now, where the coronary height seems to be a major determinant as well as the sinus size. But obviously it's more than that. If you have a leaflet that's very short, it's not going to obstruct. So I think Jaffa is obviously onto that point. You need the leaflet or cusp height that's longer than the coronary height, otherwise nothing obstructs. So in a native pathology, you really need a fair bit of calcium and pathology at the tip of the leaflet to really cause coronary obstruction. And on top of that, you need a narrow sinus or narrow VTC or a bit of calcification. So the difference between native and bioprosthetic AVR coronary obstruction is that the surgical valve can lead to sinus sequestration more than native. In native, it can happen as well if you really stretch the valve. But in sinus sequestration with bioprosthetic valve, the point is that the leaflets can be quite long, and the leaflet can touch the STJ in such a manner that you have sinus sequestration, so that it's almost like a tube graft once you put the valve in, particularly externally mounted leaflets. And these are probably a better case in terms of leaflet modification or electrosurgery, because you don't need to be absolutely spot on. You can cut anywhere in the scallop. Usually there's flow into the coronary. If you have a leaflet right outside the ostium, then you have to be absolutely perfect. Not so much of just the traversal, but the laceration needs to be quite good. And this is why we also favor balloon-assisted BASILICA. And I think we heard this yesterday. If we do crack the valve, make sure we measure the new cracked valve size. So snorkeling is one efficacious method, perhaps not as elegant, mainly because of coronary access in the future. Although in the limited studies and outcomes, they seem to be equivalent to BASILICA. We've seen this before. This is as good an illustration as anything in terms of understanding the concept of BASILICA. So we set it up slightly differently, and this is, I suppose, lessons we've had over the past 4 years or so doing BASILICA. We do not have a pigtail in the left ventricle on the ipsilateral side. We think that it's easier to just cross afterwards. So we don't use a dry seal. We just use the E-sheath that comes with the Edwards. And then on that side, all we have is a donor catheter. And our setup is usually a 90 centimeter guiding catheter with a pigtail. I know Simon mentioned about the pigtail with the unicorn, but we like the steerability. We don't have the pachyderm catheter obviously now, but we also use a microcatheter, short guiding catheter, 7 or 8, and long pigtail, 1, 2, 5. So that gives us room for a TUI. Same wire setup. On the other side, we favor, this is for left-sided BASILICA, we favor JR4 rather than MPA. We use stabilization wire as well. And the tip is you use your gooseneck snare to size it to the LVOT so that when you cross it, you don't need to capture lower down. I think when you snare quite far down into the LVOT near the mitral valve, you can actually catch some chordae, as we have learned in one case. So we need some aggressive shape, and this is why the pachyderm, which is on this side, we've used AL1, 2, 3, but it hasn't been as successful. And I emailed Adam Greenbaum about how to shape the catheter. So he suggested using a heat gun, and all it did was to burn my fingers. It really didn't change the shape. I have to learn from him again. But you can change the shape, but it does take a lot of finessing. So this is why we favor the pigtail combination. Nevertheless, this all came about several years ago when we tried all combination to try to traverse. So one thing about the Estado Y is that it's very stiff. Once you push it out, it straightens out most things, whether it's AL catheter, IM, even with a fine cross. We even used a steerable microcatheter, but we were not able to get perpendicularity in this narrow sinus. This kept sliding down. So out of necessity, we presented this at New York Valves just now. So our preferred option is a somewhat quasi-steerable pigtail. You can see this here. When you push the starter wire, everything straightens out a bit. So you lose that contact of perpendicularity. And this is why we favor this particular setup where you can almost go 180 if you really want to go for it. And then you can adjust the angle of attack. So this is our setup, 90 centimeter guide. Like I said, we've also learned the hard way. If you shorten a guide, you will lose the connection in the E-sheath and you take everything out again. So try not to shorten a guide in doing basilica, long pigtail, and the TUI so that we can have continued contrast injection. And this is somewhat important, particularly for native, where you want to inject and see the sinus. This is almost all our cases over the years. Patient 4 was the one that we failed and we couldn't do the basilica. It kept sliding down, so we had to retry this with a pigtail combination. Most of the valves, apart from the first one, which was actually, I think, the first in human TAV inaccurate with basilica, most of them have been externally mounted leaflets. We've done a couple of native recently where the sinus was deficient, but this is where you really need contrast and TOE, but all left main, mostly balloon-assisted now. In fact, all of them balloon-assisted, a variety of heart valves, and we crack when we want it or when we need to, and pigtail as the setup. So just a summary of some of the perhaps known findings in TAV in SAV, where your invasive gradient's almost always lower than your echo gradient, and sometimes disconcerting to see very high echo gradient after particularly balloon expandable within surgical bioprosthesis. So in terms of the setup as well, obviously if it's a heavy metal outline valve, you can almost do it without TOE, but you can go down the ladder, very visible, sort of visible, no visible post, but again using the same sort of technique. So this is where your snare should be, very close to the valve, because once again we've snared in the mitral space, and when we pulled, tried to lacerate, certainly patient behaved very unwell. This is a hardly visible valve, an epic valve, so you really need TOE in these cases, and then the native. So I just tried to show the native. There's no landmarks at all, so you need TOE. We try to engage the left main, pull back, push the pigtail out, and then traverse that way. So we now routinely do post-basilica invasive engagement so that we can show, perhaps for an acute infarct in the future, that non-TAVI operators where and how to engage. And it also shows that it's obviously worked, this native basilica, so on and so forth. But there was one case, the only case who got very sick during the basilica, and this is why we don't leave a pigtail on the ipsilateral side. We think basilica, put the valve in. But this guy actually got quite sick because this left main stenosis was missed on the CT. So he was so sick in heart failure, we did the CT and pushed on with the TAVI. But we did an invasive angiogram and realized, gee, there's that problem. Ejection fraction of 30%. So we pushed ahead anyway. But after Basilica, he was the only one who's sick. So just on that point about hemodynamic instability, it's quite an irony. If you have critical aortic stenosis, when you do a Basilica or when you do laceration or even balloon inflation, you actually can help the forward flow because you open up somewhat. So we've had cases where it's critical bioprosthetic aortic stenosis. You balloon, you lacerate, you actually get an augmentation of the blood pressure just because there's a better opening. So in this case, we did post-Basilica intervention. So I think the setup I've sort of gone over, but this is how we usually set up. I just make a few points that we've learned along the way. Contact is obviously important. This was an unusual case where I just traversed without even electricity. I don't necessarily use orthogonal view now. I think TOE does help. Don't snare too far into the LVOT. In terms of doing the flying V, I tend to really make it a V, kink it, and then denude the inner part rather than this particular setup, but much of muchness obviously, but you do want to expose just on one side. Now the laceration we also learned the hard way. You really need to have built up the tension. This is not a good demonstration. So you're pulling and pulling, but you should have the catheters on the leaflet with some tension, then you deliver electricity. Otherwise, you'll be zapping away and nothing happens. So primary operator on both wires, and the second operator tends to deliver the electricity. Most of the time, you tell the anesthetist, as Gilbert said yesterday, time to wake up. This is when the patient can get unwell, preempt, higher blood pressure before you lacerate. So the rest is fairly straightforward. So again, we feel it's quicker if you use E-sheath than Edwards, and like the perhaps limitation of the unicorn is that it's almost vendor specific, i.e. you have to use Edwards. But you know, obviously you can use self-expander as well, but change of sheath, etc. Okay, you can use an 18 French sheath, I suppose, and just go ahead with an Evolute. So this is the final result and good gradient for this particular case. So some of the questions that are often asked is TOE, TEE necessary? Not absolutely necessary if you have very visible post from my perspective, but all the same, this is obviously a complicated procedure. Why not? So if you have a patient who can have a TOE and GA, of course, but if not, let's say there's esophageal pathology, it is probably possible to do it if it's very visible post. Native, no. Homograft, probably not. Is sentinel necessary? Well, there's no data, but there seems to be a suggestion that sentinel will be a good idea for complicated TAVI, so probably. When you burn, you can see a snowstorm on TEE, and perhaps fundamentally it's just a good idea to have a sentinel, but I actually don't use it too often. Is calcium on the leaflet an issue? The traversal, you almost always will find a soft spot, okay? If it's truly thickened and calcified, I'd love to hear from the expert, but sometimes you can't, but we haven't had that problem, okay? But the calcium is not so much the issue in terms of the point of puncture. We've learned from some experience, I think, you can traverse, but your tear will then be pushed away through the calcium. So it may not be a linear tear, having spent all that time. It may be a lateral tear. So for sinus sequestration, it's not a problem. There's still flow into the sinus, into the coronary. But if it's completely dependent on leaflet right outside the ostium, if the Y gets pushed away, then you would have a lateral tear that will not work. And this is why it can still lead to coronary obstruction despite successful basilica or laceration. And this is also why we do balloon assisted every single case as well. Question is why not? If you can make it a bit safer, definitely. So I think we share a lot of interest. I learned from the panelists some of the tips and tricks, but this is still an off-label procedure. I think our problem, not just in Australia, perhaps in the region, is that there's really no dedicated forum to teach each other than in a forum like this. Credit to Professor Yin and Professor Wei, Professor Lee, that we have this forum to talk about, but it's not like you can reach out to the industry and we can be flown to your institution to teach you how to do it. So, you know, I spoke to Jaffa and Adam just a few days ago. The problem is that it's friends and family who you know that, oh, well, Professor Yin has done a lot of these, can we get some help? Even with experience, we find that it's at least half an hour additional. That's the average now, half an hour on top of the TAVI. Shortcut may be worthwhile, but we've been asking for it for 3 years in Australia. We're not getting that anytime soon, so let's hope that they get FDA approval eventually, and then maybe we can get it. Thank you.
Thank you, Papa. Excellent talk. Then the final talk will be delivered by Dr. Yung-Tsai from our hospital, the modified LAMPOON procedure.
Thank you. That's you be here to present our step-by-step. And I know that neo-LVOT is very important, especially in mitral procedure. And when you have a neo-LVOT, it got easier. That's LV distend and injury. It's a catastrophic result, and you need a multi-site CT. Sometimes you need transesophageal electrocardiography because as you can see the stroke to the septum. And we usually use the general anesthesia and the TE guidance and the preparation for transapical 1 and the rescue 1. We use the acetate wire and use a Terumo wire for the exchange of the acetate because it's more safe for the problem. And we use that yesterday. We just show a rendezvous procedure. It's very easy to use and help you to place the submarine in the left ventricle in the future procedure. So here is the procedural step, and we always put in a sentinel because every time after the LAMPOON procedure, we can see a lot of carbon debris in our sentinel basket. So that's why we believe even the patient did not have any stroke event. However, microemboli should be because we capture the carbon particle in our basket. And this is when we puncture to the septum and use the Terumo. And the Terumo is got easier because he can advance more into the left ventricle, and it will become a loop, and you can easily send to the ascending aorta. It's better than acetate directly because in the beginning we just use the acetate, and the acetate is a very strong wire and it cut everything. So that's we must pay attention when the acetate in the left ventricle, and sometimes you need to grasp the acetate in the left ventricle, and when the acetate pull out from the aortic artery, sometimes it will cause the laceration to the aorta. So that's when you use the Terumo wire, it got easier to pull out from the ventricle to the aorta. And then we kiss in the 7 French, the diagnosis, the caster and the diagnostic caster, and we can exchange the Terumo to the acetate wire. It made your life easier because there's just a minute procedure, and you can get it easier to exchange the wire. And then you split the 2 caster, and then now you can pull up and see that you can cut and hear it limited. And sometimes you need multiple times because such as this mitral valve in doing, and you cut one. If you did not happy about the procedure, and you can cut, just rotate the caster a little bit, and it directed the wire to another direction. And finally, you can see here is a slit, and get cut the anterior limited. So we use a modified LAMPOON procedure. There's a brain protection device. I think it indicated in the rendezvous, the caster. We did not scratch any wire, and no flywheel, no dishwasher perforation, and multiple cut with small energy, because the original paper suggests electrocutting with 50 or 70. After 2 times or 3 times, the wire was broken. So we think that the energy is too high. So we try to decrease the energy. 40 is the lower limit, and you can see here the 40 jaw electrocautery can make some difference, and you can see that we did not flush the detour water, still did a good job, and the multiple cutter help you to adjust the neo LV30 problem. And we have done the 39 transeptal mitral valve in bubble or valve in rim, and some of them with multi-slide CT, and then 12 with the LAMPOON procedure, and 14 without LAMPOON procedure, and the neo or VOT, we push the limit to 126, and the smallest one is 60. The patient still quite well active without any problem. So that's a pre-implantation LAMPOON procedure decrease the risk of the LVOT and push the limit to maybe the neo LVOT to 120. And the paper says 150 or 170. Last day we did a LAMPOON for the 170. I think that the residual LVOT pressure gradient is around 2 or 3, and our measurement is around 2, so that's it's okay and easy to use the LAMPOON procedure in the whole procedure.
Okay, thank you. Then we will have 8 minutes to go. We have a distinguished expert panel. Dr. Hayashida from Japan is also the course director of Tokyo Valve. So, and we also have Edgar Tay from Singapore, who is also an experienced operator. So maybe you two can start with you and to make some comment or questions.
Maybe I'll ask Dr. Lee first. I like your technique for this LAMPOON because it seems a lot easier. But I wanted to ask you, because now you don't have the flying V, and you don't scratch the inner surface, right? So I guess you're dependent on that exposed component of the wire now. And how do you actually control the location of the burn in that case? Do you have to say give a certain distance between the 2 catheters, and how many? The second question is how many times usually do you have to apply it before you get an actual adequate burn?
I think that it's quite easier to understand when you use the electrocautery in operation room. When the metal one touches the skin, you use the electrocautery, and it will burn a hole over there. So that the idea is it delivers the electrical energy, but also the thermal energy. So when you give the electrocautery, and you can see the TE, a lot of the debris or something, the vaporized tissue over there, and go around in your screen. So that's why I think the primary, that's the idea, it deliver the electricity to a small tip. However, actually the body cannot direct the energy over there. So that's it's master thermal cut and some electric cut. So it's my idea is Flyby don't help anything. It's just like the electrocautery. Why not use the electric cut? Because electric cut is a high frequency electric. So that's it give a lot of energy. And electrocautery is like the high frequency energy and the stop and high frequency energy. So I ask engineer about he know about the technology. So I just don't use the Flyby because it got easier because you do a thermal cut but not electric cut. Ideally in the paper it's an electric part. However, if you do in vivo test, it generates a lot of energy if you do electrocardiography. So you know the body is a huge resistance, so that when you give the electric power and it have a lot, it generates a lot of thermal, so that every time if we have some broken area and you touch the electrocardiography, it make a hole over your head. So that's I think the thermal injury is the most to the LAMPOON procedure, but not the electric injury to the liver tissue.
So thank you very much. I am very much impressed to see the older presentation because none of the procedure are approved in our country. And I would like to ask Karl that you nicely demonstrated the step-by-step procedure of the tips and tricks for the BASILICA procedure. So how many percentage of the patient require leaflet modification before tab in SAB or tab in tab procedure?
I can't really tell you a denominator, but I suppose, let's say we've done 20 cases over the past 4 or 5 years. Out of those, assuming 10% valve in valve, probably 5% perhaps, yeah.
So have you experienced the case of the coronary occlusion even after leaflet modification procedure?
We haven't, but I think one of the reasons perhaps is we have a fairly low threshold to do BASILICA. And one of the common criticisms is that, you know, it's not needed anyway. Like all things that's a little bit aggressive or complicated in what we do, it's not needed until you really need it, right? Until you really have that coronary obstruction that's very hard to get out of. So our approach is always to do it just in case, because to salvage sinus sequestration is not easy, if at all possible.
And I also like to ask the question, Simon. You nicely demonstrated how to perform the unicorn procedure. And did you have some resistance to cross the leaflet? And did you also experience some en-bloc complication after procedure?
So thank you. So for crossing, and usually crossing the wire is not a big problem. So electrophysics, the RF needle is good to pass through. And you can also use a starter wire. So it's also, actually could have some benefit because if it's a strict wire, when you come out of the catheter, it's even more precise. The J-tube is a compromise between the loop and also the strict wire. But the difficulty sometimes is just like CTO, after you crossing the wire, how to pass through the microcatheter down. The leaflet is moving, but actually you're splinting it, but it's very stiff, very tough, especially for the bowel prostatic degeneration. So sometimes it takes some time for the microcatheter. You will usually use a Navi cross to pass through, but just like CTO techniques, you can have your way to go through. So this is usually the step that is quite crucial, and after that, all the things afterwards will be easy. We don't have a big number, but so far every patient works well. We still do protection in all of the cases for coronary because we're so new to this. Although I think it's promising, but we know the limitation. We need more data verifying it, but we do protection and we prepare for the worst. But luckily, nothing happened so far.
Did you get something inside of the protection device?
No.
Okay.
No, I think you. But I would say. We don't think it's related to that, but because we put embolic protection for every case, so it's a TAVI, then it's a reasonable capture, but we're not specifically seeing a lot of things being captured. So we do the bench testing, we have the water tank, and afterwards we screen, we use a filter. We don't find anything, but I think it's theoretically less chance of having leaflets being avulsed and go away, but then it still need more data to see. But I think also they are well experienced in this technique as well. In US, they also do quite a lot of cases, and I think so far the experience were good. Yeah.
Thank you so much.
Thank you.
Okay, is Dr. Bapat still online? No. Then I have a short question for Simon. If both coronaries have some problem, what would you do?
Yes, so that would be a very good question. And although I'm big fans of Unicorn, but Basilica is still very good because you can do double Basilica on both sides. It's doable. Although setup is more complex, but I think is doable, and if experience is also simple. But then you can do combination. So you can do Basilica on one side, and you can do Unicorn on the other side. So first, for example, you have an impression which is more at risk actually. And you will do Basilica on one side and cutting, and then you follow by Unicorn and do a side. And protection is a must for these kind of cases. And although as we said, the opening of the electronic leaflets, they go to different direction, but it's actually quite controlled in bench testing. But also depend on where the corneal ostium is pointing towards. So I think combination is a key, and probably Karl can have some more experience on this as well.
I was more asking a question, but certainly for me, I don't do double Basilica. I think the data is pretty clear that the outcome is poor, or challenging at least. So probably Basilica and Snorkel, Basilica and Unicorn seems to be a better combination. What do you do, Professor Yin, if it's a double at risk?
Currently, we just do Basilica. We never try. Yeah.
But to be frank, I think it's not always possible because the setting for Unicorn or for Basilica, you have to get a commercial alignment, and they don't align perfectly. You align maybe on the left side is good, but on the other side is not that in that direction. So probably certain width will be in a hard team decision. So we do is still an option for the patient, then we should also take that into consideration. But probably the most effective way is to choose one for Basilica, for modification, the other side would be for chimney stenting. So I think this is easier to manage. Yeah.
Okay, so perfect. So it's time to close this session. I believe that this kind of electrosurgery will be quite crucial in the area of the lifetime management and for the indication of the much younger patients. Thank you very much, everyone, for the fantastic talk.
This session is more focused on tricuspid valve intervention, especially TEER therapy. So we will have a few distinguished speakers this session, including Professor Alex Lee from Hong Kong, and I'm Dr. Lam from Hong Kong as well, and Professor Song from Beijing Anzhen Hospital, and also Dr. Hu. I believe he's trying to make it here. And we also have a very distinguished panels here with Dr. Chen and also Dr. Tay from Singapore and Simon from Hong Kong. So we have a very tight schedule. Maybe we should start. And we all know that tricuspid valve intervention, especially TEER therapy, is really what I call TE guided repair, TEER. So the imager is the most important. So I think for this most important session, so we will invite the imager to give a talk first. So Alex, it's your turn now.
Okay. Okay. Can you see my screen?
Yes.
Right. Okay, so thank you very much. I'm so glad the organizing committee had involved me in this wonderful section. I'm asked to give a talk on the ICE and TEE for tricuspid TEER. And so to talk about 3D eyes, it's first of all, we need to understand that it is now only available in USA. It's not available in Europe, not in Africa, not in even other cities or countries outside Asia. It's only available in Hong Kong. So Hong Kong and USA this month seems to be the only places that ICE is available. So we are honored to be here to talk about it. Now, these are the three eyes vendor that we have come across. We have the Siemens Equinef, the Philips Pro from the Philips, and Nuvera from GE. They're the three eyes come across. Now only the Siemens and Philips have their eyes tested in Hong Kong. The GE, we are still waiting for it to be available. So because today we talk about tricuspid eyes, so I only focus up on the Philips eyes system. And so the Philips eye system had three parts. It is the Veracyte Pro catheter, the patient interface module, and then the Philips Epic ultrasound console. The three together form the Veracyte Pro eyes system. Now the eyes has 64 discrete elements, and it is 2D only probe, and it has a small footprint, only 9 French. And when we look at the Veracyte Pro 3D eyes, it has 840 discrete elements. So the more discrete elements means the more information where we're able to get from the patients. Despite that, we are able to keep it a very small footprint with 9 French all along, and to give us a 90 × 90s 3D field of view. So pretty amazing. Now this is the control element of the eyes. We have the interface of the ultrasound. Let's say when it's inserted into the patient's body, it has an interface like this. It's pointing upwards, and it's in the same interface at the punch knob. The punch knob is a element to allow more tension, control more tension on the flex wheels, or it simply can provides a steering lock is to lock the steering, and it has also four way of elements meaning AP steering, and then the LR steering. Now, this is the eyes image. So home view, you can see the tricuspid valve. The P here is the marker of the steering, and is on the left-hand side. This means the proximal end of the steering angle. The eyes element, it's actually a very good news for the images, is that all of the eyes controlling function are available in TEE, in 3D TEE, element. So we have the 2D imaging, we have eye rotate, live explain, color and spectral Doppler, and all the 3D modes, including the spectral rendering mode like a true view or true view glass, and the 3D color Doppler. They are all available on 3D. What's available on 3D TEE are also available on 3D eyes. Now we also know that the eyes can do a digital steering in terms of eye rotates. So we can electronically rotate the imaging plane without moving the eyes. It's available in 2D and color Doppler, and it's rotate from negative 90 degree to positive 90 degree in 5 degree increment clockwise or anti-clockwise. Again, we can have an X-plane, which provides 2 full resolution planes simultaneously. It allows us to capture as much as information as in same amounts of time in conventional 2D imaging. Now let's compare it to the 3D eyes. To 3D eyes, it has a square element, square aperture, and it has a 0 horizontal to shaft. In Verisight Pro eyes, it has a rectangular arrangement, and its 0 degree is in line with the shaft. Now, this is the most important slides in my lecture, so we have to understand this, the only difference between eyes and TEE. Now, eyes has a rectangular aperture, so it has a wider aperture along the shaft of the ICE catheter, and a shorter aperture along the across the shaft of the ICE catheter. So the wider curvature means the resolution will be higher. So it's from 0 degree to 60 degree. You expect the resolution can be much higher. However, when it's more than 60 degree to 90 degree, the resolution is not as good. It's bad resolution, and you don't want your images, the area of interest, to be in the bad or resolution zone. You want to keep the area of interest, the images in the high resolution zone. So this is an images of eyes. X-plane, and it's a 0 to 90 degree. Now look at the 0 degree, is beautiful image, as good as the 2D conventional 2D images. However, in the 90 degree plane, you see the image is blurred. It's poor resolution because it is in the bad resolution zone. On the other hand, if you make a 45 and 45 degree plane images, you get good images in both X-plane, and both X-plane can give you a good resolution zone because you keep the images, the area of interest in the 0 to 60 degree high resolution zone. So by default, the eyes machine allowed you to make an initial by pane touch angle to be 0 to 60 or negative 45 to positive 45. This will be the best angle you have to get the quick angle images on the eyes. Now, let's see some tricuspid valve. Okay, these are some tricuspid valve looking from the biplane home view using the 3D as the 3D to show it. On the left side is the HVR mode, a mode that can really can scale up the temporal resolution to make the temporal as high as 21 Hertz, but the spatial resolution is further down. On the right-hand side is the 1-bit mode. It can give you a better resolution, but the temporal resolution is worse, only to 7 Hertz. This is another example showing the triclip in the 3D eyes, and then you can see on the left-hand side, it is showing the biplane of 0 degree and 60 degree. Both are in the good resolutions imaging zone, so both give you a very good images. On the right-hand side is the biplane image showing the perfect image and a perfect clip arm orientation. Now let's show you a case of our own experience. So this is a 70-year-old patient with a chronic atrial tricuspid regurgitation undergoing tricuspid TEER. So this is a TEE, okay, so severe TR and severe hepatic vein systolic reversal. Now we do TEE to, as usual, highlights the anterior and posterior leaflet length, anterior leaflet length being 2.5, posterior leaflet length being 1.35. So very routine here. Now we skip to eyes. You only need to press one button to go to the eyes. And this is the eyes. And this is the conventional home view. You don't need to do a lot. You get a home view. And this is the biplane view, a 0 degree to a negative 60 degree. So give you a quite nice view of the tricuspid valve. Now we do the 45-degree view on the eyes. The eyes is not giving you much of the images, despite we adjust to the negative 45 view, because we haven't not adjust the eyes probe yet. You have to adjust the eyes transducer per se in order to get an excellent imaging zone. Remember, we have to put the area of interest in the high resolution zone. So this is not enough. This sometimes is not enough to give you a high resolution zone. So how to move it? How to move the transducer? It is something the interventionists have to learn. Now, in the old days, I taught the use of a triclip. It is exactly the same to move the eyes probe. It is the same movement than to move the triclip probe. When you use the triclip probe, you insert and remove the triclip. You counterclockwise rotate. You clockwise rotate the triclip. All the movements are the same for the eyes transducer. If you know how to move the eyes probe, the triclip probe, you will know how to move the eyes probe. All the three are the same. If you advance, if you withdraw, you advance or withdraw the eyes probe. If you counterclockwise and counterclockwise rotates, you will move the same motion of the ICV probe. If you flex and extend the triclip, you will anterior or posterior rotate the eyes probe. All the view are exactly, all the motion are exactly the same, except for the lateral septal knot triclip, it will slightly difference from the RL knot rotation, but in essence, it's still very, very similar. So we move the triclip. So this is the images before the image-guided ICE probe manipulation. You can see the red and green plane, they are already set at the 45-degree Celsius, as 45 degree, but the triclip is not set into 45 degree yet. So you see a blur image. Okay, everything is blur. It's black. It's bad resolution. All right. Then you look at the image, ask the interventionist to rotate, to move the ICE probe. After the image-guided ICE probe manipulation, you see the images are better now. You move, the interventionist move the triclip to be parallel to the 45-degree imaging plane, which is of the red imaging plane. Now the images will become perfect. You can see the triclip very well. The two triclip. Now you go back to before the ICE probe manipulation. You can't see anything. You have imaging artifacts. Your keep arm position is not right, but after you rotate the ICE probe according to the 3D images, you got a perfect scenario. You got to see the ICE, the triclip images all along very well. You see the insertion of the leaflet into the triclip. This is all you want to see during a maneuver. You see the ICE. This is the ICE. This is not TEE. The ICE showing still the same 45-degree images, but it shows the triclip being shown the leaflet insertion in the exact view. This is a good leaflet insertion. This is a 3D ICE, and on the other hand is the X-plane ICE. Excellent images. Of course, you cannot entirely rely on ICE. You have to make use of TE as well, especially look at the keep arm orientation. None of the ICE orientation give you such a beautiful orientation as in the transgastric short axis. This is the only way to look at the keep arm orientation with the TE probe. Again, with the TE probe, you can do a transgastric 3D M-TEER to look not only to the perpendicularity of this triclip, but also you can see the leaflet insertion pretty well. So the gripper down, the gripper is down, and you see the leaflet insertion very well, and you ask the interventions to close the gripper, and everything is done nice and well. Leaflet insertion, good to see by eyes. Also, it can be seen by a TEE, but sometimes if you can't see it by TEE, then eyes will be the images to help. So these are some of them eyes, some of them TEE. You can see how they correlate each other, and TEE is better in the residual TR assessment for now, because the TEE color Doppler is more sensitive and could be showing a larger TR just than TE. So we still rely on the TEE to assess the TR. There's a TEE final angle showing the much better TR and great leaflet insertion. Again, we need this TEE probe to help us to look at the short axis. The two dual orifice origin is not to be missed on the TEE. So let me summarize. 3D eyes can provide a better grasping view than TEE mid-esophageal view by avoiding shadowing from the left heart structure. There's no eyes nose to the eyes view identical to the transesophageal echo, transgastric, tricuspid valve short access. Very, very important to remember. TEE is still the thing you need if you want to see the tricuspid valve short access. And due to this high sensitivity of eyes, eyes color Doppler is currently not recommended as the regurgitation severity assessment. We still go back to TEE for that. But combining the TEE at the transgastric view and the eyes at the mid-esophageal view, we will able to provide a great imaging view for tricuspid valve with ensure image quality and lower risk of esophageal injury, because we no longer need to move the TEE probe so much. So due to the limited number of elements in the vertical direction, X-plane and 3D images are, really bad at 90 degrees for eyes. So now you need to have a learning curve to how to manipulate the probe to optimize the target planes within the negative 45 to 45 degree high resolution zone. So with that, I would like to end my talk. Thanks very much.
Thanks, Alex. Very enlightening talk. So for the interest of time, maybe we leave the question and answer session at the end of this session. But I would like to thank personally Alex for supporting me all the years. And I see it is important, really, we continue to work closely with each other and learning all these new tools. And hopefully keep providing good services to our patients. Yeah, stay healthy.
Thank you.
And we have many years to go, buddy. So let's go for next talk.
Okay, next I would like to invite Wei-Hsian Lam to the stand to give us a talk on troubleshooting of the tricuspid valve TEER. Wei-Hsian is a well-known operator in these transcatheter procedures. And well, Wei-Hsian, give us a talk.
All right, so first of all, I'd like to thank the Professor Yan for inviting me here to this very important Asia Heart Valve meeting. So I was asked to talk about this troubleshooting of tricuspid TEER. There's a lot of challenges when I prepare this talk about tricuspid valve TEER. And the current state of art device now is TriClip G4. So most of my talks are based on my experience of using G4. And the availability of this SL knob to correct septal hugging, and also this independent grasping. What I don't call it independent grasping, I call it leaflet optimization function, because most of the time these functions help us to get additional few millimeter of leaflets, really improve the outcome of the patient. So when I think of challenges, these are the 4 areas I would like to touch upon. The anatomy, always complex, imaging, difficult. We have difficult patients with a lot of comorbidities, and they have other cardiovascular disease, not just tricuspid, maybe having mitral, coronary atrial fibrillation, etc. And also, at the end, I would like to touch a little bit about treatment durability, because nowadays we don't have any data. So I would like to comment on that. So let's go for anatomy and patient selection, because this is therapy I think is way more complex than mitral TEER. And at the beginning, you want to select your patient. You want to select perfect patients, so you gain experience with this system. That will actually help you to tackle more complex cases in the future. So we know there are 4 types of TEER, but majority of the TEER we're treating today are mostly atrial functional TEER. It's different from mitral plates. We have a lot of organic disease. And another area is the lead-induced TEER. I think we will see more of these in the future. So I don't have time to go into lead-induced TEER. It can be a really long talk, but I think nowadays when we see lead-induced TR, most of them are underdiagnosed because you are not talking about the lead adhere to the leaflet. Most of the time we are seeing this dynamic compression of the lead on the leaflets, because sometimes when you implant the lead, maybe the redundancy of the loop is not adequate. So we don't create a loop in the right atrium, so the lead is actually stretching like that, and during systole it will compress on one of the leaflet and causing TR. During diastole it's fine. This is the patient that we could easily treat because the pathology, we can actually isolate the lead by TEER and then the TR will improve significantly. What we are worrying in lead-induced TR is patient really had this organic interaction with the leaflet, adhesion, perforation, entanglement with caudal apparatus like this case, because we cannot treat where the lead is actually causing the problem, and that's where you have the largest amount of TR. So of course, at the beginning, you want to treat patient really not that severe. You know, when you have torrential TR, you have big gap by definition. So these are the patients you want to avoid at the beginning. And when you do patient selection, so apart from the gap I mentioned, the big gap, you try to avoid anything more than 7 millimeter. You also have to look at the quality of the septal leaflet, not just the length. It also, you need to look at whether it's being tattered. So if it is short and tattered, it's more difficult. Gilbert actually put a perspective of talking about coarctation reserve. So not just looking at the length, but you see how the geometry of the tricuspid valve complex is changed in atrial functional TR most of the time. So if this symmetrical V is better, if you go with asymmetrical V with a tattering of septal leaflet with a bit of gap, is worse. If you have flattening and there's a big gap in the central, and that's even worse, more challenging. And this is the case that I don't think you want to treat it with TEER. So there are cases with a lot of tattering, big gap. So you have to understand these are probably options for other transcatheter interventional options. And this is a perfect case where you have good mid-esophageal imaging, like I show you, the screening TE, and also transgastric view, you see there's some gap, and the leak is mostly anteroseptal. This is where you want to clip, and it's easily clippable, and the gap is not very big. And usually you can get away with just one clip close to the middle of the leaflet. Also, I think Rebecca is very good at try to find, categorize the morphology of tricuspid valve leaflet. What we are seeing in clinical practice is we don't normally see all cases are really tricuspid. They are quadricuspid cases. Why in this case it would be a problem? Because in these cases, basically you can imagine there are multiple claps based on this morphology. In tricuspid valve leaflet, usually you can consider AP, this commissure, as a clap, because you know when you have a mitral clap, you try to avoid pulling open the clap. So when you have more leaflet, then you have problem of pulling over the clap, right? So when we do like tricuspid valve clipping, remember there's a clap in the middle, AP commissure. If we put these two clips too wide, the angle is too wide, you're going to pull open this clap. And if you have multiple tricuspid valve leaflet, well, then you have problems to decide the orientation of your clips, especially when you go for multiple clip. That's why you might have higher chance of distort the leaflet, and then you ended up with suboptimal results. And of course, thinking about tricuspid, you have to think in some cases, when you intervene really late, then you may not have good outcome. So you want all your patients to have a smooth procedure. After procedure, their symptoms get better, their prognosis get better. So if you can avoid, try to avoid the patient really having very bad RV function. And of course, we know imaging is always a nightmare for this procedure, and especially TE, but it is really essential. So this is a single center study. Well, physician tried to pull up a score based on whatever I said just in a few minutes, last few minutes, to look at the gap, look at the septal leaflet quality, to look at whether this is really multiple leaflets, where's the JAG, TE quality, And these will all impact on the result of tricuspid valve TEER. So try to select a perfect candidate like mitral valve area. We have this green, maybe yellow zone or red zone. It's not that clear cut in tricuspid area, but I think the good case is a patient with good leaflet length, gap is not large, you have excellent T images where the lead is anteroseptal procedure, and then you don't have a pacemaker lead, and RV function is good. So this is the good candidate to start with. All right, good patient selection is the key to success. This is first point. But having said that, there are ways really to improve your imaging quality. One is through multi-level T imaging. So we can advance probe at multiple levels, try to get you the optimal angle. And I found this C level, the tricuspid valve, trigastric view, as Alex said, is very useful. And of course, we have advanced software like multi-view or adjustable modify X-plane angles, help you to achieve the optimal angle with good images. So this is the imaging protocols that we used together with Alex. So you see we use a lot of 3D multi-plane reconstruction. One, because we want to reduce the risk of having additional manipulation of the probe, having esophageal injury. And two is actually it is fast to do that. And we know that during tricuspid valve imaging, I always said there are 4 family members, so port, P-O-T, and G. So P-O-T is actually more important. Port means position, orientation, and trajectory. And then finally is G, is grasping. So a lot of people focus on grasping, but in fact, port is far more important, especially the position and orientation. And this is where I think the transgastric view is very useful, and Alex already mentioned about that. Just to illustrate that, I show you a case. It's 92-year-old, atrial fibrillation, severe TR, had history of stroke. We plan to do a tricuspid valve TEER and LAO. So this is transgastric 3D. So few points, maybe I just try to highlight. First, we have to use this plane, green plane, to reconstruct the true on-fast tri-leaflet plane. Instead of having 2D, this is the real on-fast tri-leaflet. And the second thing is we try to position where the area of interest, we want to assess the pathology. Like in this case, we think this is a really atrial functional TR, but it's not the case. You see that we actually, the point of the most regurgitation is at the posteroseptal regurgitation site. When we position the area of interest at anteroseptal, it's not that bad. That's why the first clip we actually target at the pathology is the posteroseptal, where you have small septal leaflet prolapse there. And then the transgastric view is very important in another sense. It's the only view you can assess orientation and grasping at the same time. This is something I think is very important because we really want to put it at exact position, good orientation. And you can see that when you close the clip in transgastric view, you can see this appearance of ribbon sign very clearly. So pulling up of the leaflet. So that's why it is always impossible. It is always important, and even with eyes, because eyes don't have this. So that's why I was a little bit disappointed. Eyes cannot really replace TE at this stage. So for the interest of time, I skip to this and I talk about a case. So this is a case, 85-year-old, multiple admission for heart failure, very poor mid-esophageal imaging, very big gap. Basically, this is more than 1 centimeter. Basically, you should be out. This is something in the rest zone, but there's no option patient. And this was like 6-7 years ago. We don't have replacement option yet. But I actually do a very simple maneuver. When we do TE screening, I ask my assistant to press on patient's chest wall, and the gaps reduced dynamically, just 1 second. So I realized that with some maneuver, you actually can reduce the gap. There are few ways to do reduce the gap. Of course, one is through chest compression, another thing is to sipping technique, put one at the commissure and then facilitate the one in the middle. And these are the strategies that you can use before operation, diuresis, and then there are some maneuver like head tilt during the operation, ventilatory maneuver, chest wall compression, sipping strategies. These all helps in big gaps. So in this patient, we actually is lucky to find a lower esophageal view where you can avoid all these acoustic shadowing. So the clipping was performed in the lower esophageal instead of mid-esophageal view. We put in 2 clips, and luckily this is before and this is after it ended up with trivial TR. So there are ways to correct a big gap, poor imaging. So TE is difficult, especially transgastric view, but this is also very important. If you can get very nice 3D picture, it is essential for the procedural success in majority of our patients. So Alex talked about ICE. You also understand the limitation of current ICE. In TE probe, you have 2,500 elements. So basically 0 degree, 90 degree, you get excellent image quality. With Philips current generation ICE, is always difficult. So you sometimes have to manipulate your catheter to adjust the imaging angle. I think that's one key challenges. That's why Alex talking about adjunct use. So you want to shorten the procedure, then you put TE in the transgastric for orientation, for grasping. You put ICE catheter at mid-esophageal view. This is more for confirming of leaflet capture. But this would be more expensive, of course. And so I skip this. So I also skip this case. I think this case I want to illustrate with you. Even with ICE, TE, sometimes we have complications. So this is a case I have SLDA despite having 2 imaging options, and luckily we put in 2 clips and eventually we achieve good results. So yeah, 3D ICE is often adjunctive to current TE and make the procedure easier and faster, but it would be more expensive. SLDA, whatever you do, the reported literature is 3 to 4% happening. So if you happen, then don't panic. It's often salvageable. You put 2 clips side by side. Usually you solve the problem. So I go for the case 4 because I want to talk a little bit about treatment durability. So this is an 86-year-old, a very large tricuspid valve annulus due to atrial fibrillation. I do K-clip annuloplasty first with 2 K-clips 2 years ago. And then the patient coming back for heart failure symptoms. And I did an echo again. I found that the TR getting worse. And also the patient had MR also getting worse. So this is the patient we are treating today. And so this is 2 years ago. You see very bad TR. MR is moderate, not that bad. And then this is a 3D showing you very bad TR. Is all over from anterior septal to posterior septal commissure. And this is how I did 2 years ago. So I put 1 K-clip and then I put another K-clip. And this patient's TR ended from torrential to moderate. And this is, Song is here. This is a method proposed by Song. We should actually try to put in additional K-clips. So it's more like a partial annuloplasty, try to string down the annulus even smaller, and then you would end up with good durability. And after the procedure, after we put in 2 clips, you see the MR actually went down to moderate, but it's more on anteroseptal side. This is what I'm worrying, because I worry that for atrial fibrillation, the annulus continue to dilate, so the patient will have more leak, regurgitation in the anteroseptal region. When during follow-up, this is exactly what happened 2 years afterwards. So her MR get worse. So you see this MR and this really challenging cases for TEER because of calcified posterior annulus, very short leaflet. This is #1 challenge. And then this is a patient had a true clap in the middle. So and also this is the patient with a lot of like calcific, mild calcific MS. So you see the baseline, the mean gradient is 3, but the pressure half time is really long, and the mitral valve area is small. So apart from, and then we look at the TR, is really definitely getting worse. And I do a quick sweep. I look at the septal leaflet quality. You see in some region close to the annulus, this is really frail and fragile, very short. So, but this 86, no other option. And so you see this transgastric view here, it's very short. So this is the only chance, very limited grasping option. So in this case, I do first the mitral using a small narrow clip. This is dragonfly, this is not. And then I put another clip, long and narrow at tricuspid valve position, and I'm able to achieve a reasonable good result. So bring down to mitral. I put a very small clip, and with mild residual MR, the gradient raised from 3 to 5, I think is fine. And then tricuspid, I try my best to optimize leaflet optimization, try to reduce SLDA. This is something that I routinely do for tricuspid valve clipping. So you see, nearly every cases I try to aim at the annulus region. And this is the ribbon sign, very clear, and this is the TR after post K-clip failed TR recurrence at anteroseptal region. So this is a 3D picture, so showing still some TR with 2 K-clips here. So sorry for this overrun a little bit, but I want to say a few words about durability. So this is a slide just presented a few days ago by Matthew Price, and he looked at the Triluminate study and looked at the TR distribution in this trial. So most of the TR is around this central region, and some of them extends towards more anteroseptal commissure. And the clips they are using in Japanese and also some American cohort, they tend to use a long and wide clip. I think in Asians may not be that appropriate because you know, when you use a wide clip, it's always difficult to maneuver the clip, and you, especially when you go for anteroseptal commissure, then you have problem of entangle the cord. So I tend to use more commissural long and thin clip, and then in the middle maybe wide clip. And posteroseptal usually is thin clip because posteroseptal you have some cordies as well. And this is the clipping strategies being used in the trial, and including they call single clip, multi-plane, that's modified Clover, and the zipper techniques. And in this trial, they were able to show with different strategies, no strategies ever shown to be superior to other. Although if you look at zipper, it seems that the residual TR is more, but using zipper techniques are all those patients with torrential TR, so that's probably the reason. So the optimal clipping strategy, the best clipping strategy which impacts on the durability of TR reduction in atrial functional TR. I would say the most common patient population for TR remains unknown. And so maybe I would propose, if imaging allows, if your technique allows, we should go for more aggressive clipping strategy. Like this is what I try to do. So I put 2 clips in anteroseptal, long and thin, long and wide, and if feasible, even with the TR is only mild moderate degree at posteroseptal, I go for the clipping, just for long durability. Of course, this needs to be tested in more data. And of course, you have combination strategies as well. So like in the last case I show, if you have posteroseptal pathology, anteroseptal pathology, maybe combination in some selected patients is the way to go. Thank you.
Thanks.
Thank you very much, Wei-Wei, for the excellent talk. So we'll move on to the next speaker, Dr. Cheung Guang-Yuan. Dr. Cheung is a very expert interventionist in structural heart. He does a lot of TAVR, TEER, as well as LAA, and he's going to talk to us about tricuspid TEER in China. Dr. Cheung, please.
Thank you, Simon. And also Professor Yin and Professor Lee for inviting me to join this session. I'm going to report the transcatheter tricuspid editorial repair in China. As we all know, tricuspid valve, we always have a lot of patients in China from the DVD study. 45% have co-current tricuspid regurgitation, and the pure tricuspid regurgitation accounting for around 17%. Unfortunately, we have more and more devices because the surgeons always are reluctant to the open heart surgery to treat the mid or late stage of tricuspid regurgitation. Now we have, just like Wei-Hsian introduced, we have annuloplasty device, except cardio band, but we have key clip. It's very easier to manipulate. And we have leaflet repair, but we don't have this, TriClip and Pascal. I will introduce later. We have a replacement device. For this, we can know, we don't know, the TEER procedure, if it can, improve the outcomes of for the mortality and, for the rehospitalization. But from this study, we can know it can effectively improve the NYH function class and quality of life. So I'm going to introduce from 4 aspects. The first one is enhanced tricuspid imaging expertise in China. I think with the help of Professor Lam, Alex, and Scott Lam, we are learning more and more imaging from the tricuspid regurgitation. But we do know that the tricuspid valve, they have thinner leaflets. They hiding behind the sternum, not good always for the TTE. Unfortunately, now we are using more and more TE, and also Alex introduced 4DIs may be available at the end of this year. We always have acoustic shadings and variable morphology. Actually, we are using more and more like medial sofa and deep gastric. This is rare before in mainland China, but it's using more and more popular now. And also the multi-view imaging is also more and more important during even the TEER or the annuloplasty. Maybe in the future, we are going to have more and more fusion modality of imaging in the pre or in procedure evaluation for the tricuspid valve. The second one is innovative T-TEER devices. As we all know, we have many companies. They are focusing on the mitral valve regurgitation. I think it's easy to convert to the T-TEER device. So the first one is Dragonfly T and the current T, and many clips they transferred, to the tricuspid valve TEER. This is a stage they are on right now. The first device in China to treat tricuspid regurgitation is Dragon T. And 2022, Professor Wang Jian'an, they use Dragon T to complete the first TEER in tricuspid valve with Dragonfly T in China. So from Dragon T, we can know we have even a longer and wider device compared with G4 system. But the Dragon T is still on the feasibility study. Maybe they will transfer to the pivotal study at the end of this year or next year. But from the feasibility study, this is a comparable device compared with G4 system. Another one is Korean. T. Also have 4 sizes of clips. Also independent leaflet capture. And the feasibility studies finished 12 cases. I think the result is good. They have 91.7% to less than moderate TR after the procedure. But for most centers, we actually don't have a lot of experience with T-TEER, but we are learning. We actually know which is device specific challenges. Maybe we will have TriClip the next year, so we can compare directly which is good, you know, for the large gaps, for the tethering valves, and also we are learning the T-TEER scoring, and also like what I said, maybe we need to aggressive T-TEER strategies, like at least 3 clips, 1 clips in the commissure between the anterior and septal, and then in the middle, and the other one is posterior and septal, to get a better result. And we don't have enough data to know what's our outcomes of right ventricular modeling and the pulmonary vascular hemodynamics. But we do learn. They have study from the Illuminate from New York Valves. The other one is the one's management of concepts of TR. And Professor Lu Fanglin, he draws the conclusion, he draws a definition of tricuspid regurgitation syndrome. He explained so different stages of tricuspid regurgitation, and help us, you know, to easily find which is good point to treat tricuspid regurgitation. But actually, we are still in the early stage to learn. So which one is like decompensate during the stage of tricuspid regurgitation. And also we know that we still on the learning curve, actually, how to choose the right patient and how to risk to define, you know, which risk they are having to use TEER strategy. I think TEER, we are still on the learning curve. What's TR reduction or the recurrent TR after TEER, and the symptom improvements and the hemodynamic enhancement, and also the survival benefits. We need to have a long follow-up to say that TEER is really good, you know, for tricuspid regurgitation. The future, just like what I said, I reported modified key clipping strategy in New York Valve. I think we do have the possibility to combine like annuloplasty procedure with a T procedure. Like this is a severe tricuspid valve regurgitation. We used modified K procedure. Now with a 2 clip, we can see it's only minimal tricuspid regurgitation after the procedure. It's only mild. Yeah, but we do, you know, reduce the annulus of a tricuspid valve. Before is 13.4 as a parameter, and after the K clip is 8.7. I think this will, even we don't have good result, we can have like minimize the gap between the leaflets to make TEER to be possible, and also we can do the replacement even after the key clip. To conclusion, I think in China mainland, we are still in the learning curve, including the imaging and the device specific strategies. And also we need to accumulate interventional experience. But T-TEER, I think, is not only the technical breakthrough, but we need to choose the right time, right procedure for the right patients. Thank you.
Wai and Alex, I have a small question about the combined TE and the ICE used during the TEER procedure, because one is in the head position, the T, and then the other one will be in the femoral position. So you have a more echocardiographer doing the procedure during the TEER, during the ICE and the T. And also the second question is that the ICE, will the ICE interfere with the TEER procedure because it's in the same IVC and then in the same RA and then they move in the same directions?
So maybe I answer first, Alex can compliment me as well. So usually we would, the interventionalists will control the ICE, and then the imager will help us crop all these imaging views. Because this current ICE generation, we put it, usually we do the clip on the right femoral vein and we get access of ICE from left femoral vein. It's only 9 French. So I found it actually quite okay and there's no interaction. But if, let's say the ICE, we have 2 other vendors, if the ICE and the T are from 2 different companies, then of course you will have like some ultrasound interference when you, so using other companies' ICE, you have to turn off your Philips machine and then you switch around. But with the same vendor, there's no problem. You just one button, then you can convert from ICE to TE perfectly. Yeah. Also, I have one question to ask Alex. Is it possible to advance the ICE catheter to the stomach and then you get some short axis view? Had anyone ever done that?
I don't think it is anatomically feasible. You put the eyes into the stomach, and it is still where the TEE should be the best imaging modality to do that. So to answer the question, yeah, the imager now dedicate one of his tasks, which is the manipulation of the ICE probe to the interventions. Now, interventions are going to move the ICE probe. Fortunately, there isn't much to do. The essence is to find the great angle where you put the area of interest into the best resolution zone, then the images can focus on something else. It's now then the images, 3D images, will be pumped out for the interventional imager to play with, and all the cropping. The important thing is the 3D, and from 3D we will crop, using the multi-plane reconstruction to crop all the required image. That's the intervention we need. So it's really quite simple. And I don't think it will interfere with one another. The only thing that will interfere with the ICE probe is the TEE probe. So you cannot have both TEE and ICE turn on at the same time. So you have to switch, turn on one and turn off one. Otherwise, it's quite, it will not be any interference.
Yeah, I also agree with that. And I used to use a single vendor for both machines. The good thing is it just switched over. because at this stage we're not able to get rid of the TE. I think it's the way to go, but at this point it's still like coming back and forth from TE and ICE. And the also good thing is you can save everything on the same platform, and you know the sequences, the images. There's no need to switch between devices, and to put at the head position is good enough. But then I really agree 3D ICE is the way to go. For TE, we had a bad experience of bleeding, for example, especially with patients with severe tricuspid regurgitation, they have varices, and usually you need a lot of manipulation to be very sure that the leaflets are engaged. So, and also the temperature always goes up to an extent while you're at a very critical moment. You want to make the judgment. So I think is the way to go. So I asked Professor Lee, how long do you think we need to get rid of the TE? I think Gilbert is doing something like get rid of a TE, but how far are we from that?
I think from the most important thing to get rid of the TE is that the eyes has to be scientifically be able to provide the image that is at least as good as the TE probe, and then we need at least, if it can occur, then I think it will need maybe 5 years or so for it to occur, because it is not as easy to, the TE has a major advantage. This eyes has a major advantage of being smaller. It has to be smaller, while the TE probe can be a little bit larger because it's going through the esophagus. So how to improve the resolution and the information, especially for the smaller catheter, smaller aperture of the eyes probe, is really a problem. So I hope that this will be overcome by some clever solution, but I think there's a minimum requirement that's high eyes has to occur in order to replace TE. But I think 5 years or more.
Can I ask one question?
My personal guess.
Can I ask maybe YY and Dr. Song? We have a lot of patients with this atrial functional TR, and like we saw your technique was very nice. You press the chest precordial, and then you narrow the gap and you try to do a clip. But I always think about the worry is that when you do that, there's always a lot of leaflet tension after the procedure. And I also saw that elegant case that Dr. Song put in the K-clips, and that actually can do the annuloplasty. But it seems like this hybrid option of annuloplasty plus, but this clip is actually going to be a very good technique, but the only problem here is 2 vendors oftentimes, right? So, I mean, what are your thoughts about that?
Well, we use chest wall compression in some really difficult cases. While at the beginning we thought the gap is too big, and we use chest compression. We even try in a Epstein patient. I think we published that in Circulation with Alex. With chest wall compression, you can achieve good results. Luckily, tricuspid valve is very compliant, and if the septal leaflet is long enough, usually you don't have any problem. You only have problem with those cases where the septal leaflet is really short. I think these are the cases you're worrying about leaflet injury, and so that's a concern. I think because at the end I talk about durability, I think the durability is try to mimic what surgeons really do. Surgeon is very effective in treating TR by doing an annuloplasty ring. We have options like cardio band, but due to technical difficulties, it's not popular. The technique is not popular. It's not readily available to all parts of the world. So I think the closest one for the TriClip because TriClip also had this indirect annuloplasty effect. So that's why I said if feasible, technically feasible imaging is okay. We should try to at least do septal, anteroseptal. Even the the TR is mild, we should do posteroseptal. At the same time, this is more like a more extensive annuloplasty effect. If it is not feasible, of course, I think K-clip combination with TEER is really a good strategy to go, because one take part of these posterior annulus, that part annuloplasty, and the anteroseptal put in TEER. You do this complete the annuloplasty. So with this approach, I think the long-term durability would be good. I don't think now the Western approach of doing TEER is right, because you look at the Triluminate trial, they only look at reduction of TR, even like 2 grades, they are happy. Because I have this experience of off-label use of MitraClip in tricuspid position. I think the earliest case I started was 8 years ago. And so I see a lot of patients having recurrence. And because at that time we don't know how to do it, we're happy. We just put in 1 clip and the patient had 1 grade TR reduction, we are happy. But this patient coming back for symptoms and the TR get worse. And also I think one thing additionally is important is we are treating atrial fibrillation related disease is progressive. So these patients, I think you really need to put in a team effort how to manage them, the rhythm control. Maybe some of them having diastolic heart failure, some of them having atrial functional MR, and these make the whole thing a lot more complex. And these are the things that I think we need also to be addressed in future study in order to have good outcome for these patients.
Yeah, I think just like Wei-Wei said, if we have a very big gap, even we can do the procedure, very successfully, simultaneously after the T-TEER procedure, but we still worry about maybe we have leaflet TEER or the recurrency of tricuspid regurgitation. I think maybe the annuloplasty device, they can fill the gap, like they can minimize the gap between the leaflets and also reduce the risk of TEER after T-TEER procedure. Yeah.
Thank you. It's my fault of overrun the talk, so we have a slightly overrun session, but I believe all of you enjoyed this session pretty much. So we have really a deep dive about this TEER technology, and we have good discussion about the eyes imaging. So I think these are all important areas needs to be addressed. So hopefully we'll have more of these sessions so we can get more experts to discuss and improve the TEER therapy. It's always difficult to go for repair pathway. People tend to jump to replacement. But I think the replacement, you have issue like durability, long-term anticoagulation use. So if we want to do repair, we have to do it right. So like TEER, we have to do it right. Annuloplasty, we have to do it right. I still believe repair is the first line before a replacement. So with that, I would like to conclude the session. Thank you very much.
Thank you.
Please. All the panels come up to this stage. Let's have another TEER session. This session focuses on some difficulty and controversial issues in TEER. So the first talk will be delivered by Dr. Kentaro Hayashida. The title of his talk is Lifetime Management of Aortic Stenosis. Always a hot topic. Please.
Okay, thank you very much, Wei-Hsian. So could you please, okay, yeah. So today I'm going to talk about lifetime management of aortic stenosis. And actually this topic is quite relevant to us because the indication is now shifting towards much younger patients. And this year, the 22nd anniversary of the TAVR introduction by Dr. Krivia. Unfortunately, he passed away this year, and however, this technology is prevailed to the all over the world. I was quite lucky to learn this procedure when I was in France from 2009 to 2012. However, we have really bad complication at this moment, and hope this movie works, but it doesn't work. And sometimes we have the very severe complication. We also have this kind of migration of the THP inside of the left ventricle. It was more than 10 years ago. So the mortality of the TAVR procedure was quite high. Even in 2009, when I joined Massey, it was higher than 10%. That means it was quite challenging procedure. And therefore, to overcome the index procedure was the utmost importance for us. And we also think about how to introduce this technique safely to Asian patients. And my publications are a safe introduction of TAVR procedure to Asian countries and publication from Asia as an equal partner to the global community. And I was certified as a proctor in 2012, and I was lucky to work with all of the friends in Asia. And we also published some data using the French data, and therefore we extended the scope to the entire Japan, and we organized the Ocean SCT family from 2014. And this year was the 10th anniversary of our Ocean SCT family, and the Yohei, Daisuke, and the Kazuki are the very important member of our registry. And the annual number of SHT is shown here, and we've already included more than 22,000 TAVI procedures so far. And we also published more than 100 papers so far. And these are the currently available TAVR devices in our country, and SAPIEN 3 UR, Leaflet FX, and Navigator Vision. And this slide shows the age cutoff for the indication of either surgical AVR or TAVI. And the European guidelines says it's 75 years old to be the cutoff point. And we used this cutoff point. However, we Japanese cohort have a little bit longer life expectancy, like by 2 years. Therefore, we prepared some gray zone between 75 to 80. In American guidelines says between 65 to 80, the patient can choose either of the procedure. And if you look at the data from the United States, and if the patient are between 65 to 80 years old, amazingly, 90% of the patient prefers to receive TAVI rather than surgical AVR. And even if the patient are younger than 65 years old, they still choose the TAVI in the 47% of the patient. So therefore, it's quite, the TAVI is quite prevalent all over the world. And lifetime management is quite important. If the patients are quite young, we usually start from surgical AVR, but it may require a second procedure in their 80s. And if we switch the sequence between TAVI and surgical AVR, but sometimes the TAVI explant is quite challenging. Therefore, we also think about the 3 times of the TAVI procedure in the lifetime management. And coronary access is also quite important, and the one valve is usually okay to cannulate the coronary access. And we usually try to implant the THP as high as possible to reduce the incidence of pacemaker implantation. However, if we put the THP too high, it may lead to the difficulty to cannulate the coronary artery. So therefore, tailor-made implantation depths for each patient to minimize the risk of the difficulty of the coronary cannulation as well as pacemaker implantation is quite important. In anatomical, anti-anatomical approach is quite important. And commensurate alignment is so important to be able to cannulate the coronary artery after implantation of self-expanding device. And there is some risk factor for the difficulty in terms of the coronary cannulation, ST junction, sinus height, and width of the sinus of Valsalva and coronary height. And device factors are also quite important, like the commissure tab, ceiling scar height, and valve implantation depth. So therefore, we need to optimize these kind of factors. And tab inside procedure is also quite relevant to our daily practice. We can use either self-expanding or balloon expandable device. And this study demonstrated the tab inside procedure was associated with higher coronary obstruction rate compared to tab in tab procedure. And this slide also shows the importance of VTC distance. If the VTC distance is quite short, the patient may have the risk of the coronary occlusion. So therefore, we need to take into account, and especially in the patient with the externally mounted surgical biprosthesis. And my good friend Yo-Hei demonstrated the initial result of our tab inside cohort from our Ocean Tab registry in the last year JCS meeting. And the Carpenter Edwards prosthesis was the mainly treated in our registry. And most of the patients received very small surgical valve. And if we look at the data from SAPIEN 3, and 23 millimeter SAPIEN 3 are the most frequently used. And if you look at the data for the Evolut, 23 millimeter Evolut was also the predominantly used in the registry. And all-cause mortality was noted in 1.5%, as well as the 0.9% of stroke rate. That is quite acceptable in the cohort of the very high-risk cohort. And in the previous session, we really learned a lot about BASILICA technique. And this is quite prevalent in the all over the world. However, this technique is not approved in our country. Hopefully, in the future, we can do this procedure as well. And shortcut device is very promising device, and it's just approved. It's just introduced, and we are very surprised to see the result of the shortcut initial data in the late-breaking trial of the PCR, EuroPCR, and I believe that it is also a very promising procedure to open up the indication to the younger patient. And the two TAVI devices are sometimes challenging, so we should be careful. And for example, this is the previous implanted Evolut, and implanted SAPIEN 3 might lead to the coronary obstruction. So therefore, we need to think about the how we can optimize the initial index procedure. And the CT analysis is also quite important to what's happening in the body of the patient. So optimal cannulation strategy is quite important. And the when we perform tab in tab procedure, the meticulous screening is quite important. We can also identify the height of risk planes. So therefore, we need to avoid the coronary obstruction after tab in tab procedure. And as I mentioned, explant TAVI is sometimes challenging. This study demonstrated higher rate of the mortality after TAVI explant. So therefore, we need to avoid the TAVI explant as far as possible. If we compare the repeat TAVI and TAVI explant, the repeat TAVI demonstrate the lower incidence of the coronary obstruction as well as the lower 30-day mortality. So as far as the TAVI in TAVI procedure is feasible, maybe we can choose TAVI in TAVI procedure. And we're quite happy to have this better UR from the last year. And our good friend Masaya Yamamoto demonstrated our initial data comparing S3UR and S3. And the S3UR demonstrated much lower incidence of severe prosthesis patient mismatch, like 0.5% compared to that of S3 cohort. So therefore, it will enable us to choose to optimize the biprosthesis choice. And what is most important for us is now the indication of TAVI and TAVI procedure is approved in our country, because in terms of the approval, we are quite late. And this case is the S3UR 23 millimeter implantation is a degenerated 26 millimeter SAPIEN XT. We also performed the post-dilatation because it increased up to 8 atmosphere. And finally, we reached to the peak flow velocity of 1.8, and mean pressure gradient was decreased to 9 millimeter mercury. I think it's quite important to measure the invasive measurement because sometimes the echo may overestimate the pressure gradient. So therefore, we take into account the invasive hemodynamic measurement just after procedure. And this case is the 93 years female who received the sapien 320 millimeter 7 years ago, and she developed the structural valve deterioration, and it increased to up to peak flow velocity of 4.3 meter per second. And we put the 20 millimeter sapien 3 in this cohort, and finally it went well. And pressure gradient decreased to the 12 millimeter mercury after procedure. However, the echocardiographic measurement overestimate the pressure gradient. So therefore, I insist that the invasive measurement is quite important for this kind with small annulus. And now indication is shifting towards much upstream the patient. And if we look at the data about the moderate aortic stenosis, even moderate aortic stenosis have the worse outcome as the severe aortic stenosis. And we are very much honored to be the part of the PROGRESS trial that compares the TAVI and clinical surveillance in the patient with moderate aortic stenosis. And hopefully, in the near future, we're going to have the result. So in conclusion, ladies and gentlemen, and TAVI is now established as a valid therapeutic option for the patient with aortic stenosis. Indication of TAVI is now shifting towards much younger patients. So therefore, lifetime management is quite important. And I believe that repeatability, that means the TAV in TAV or TAV in TAV is feasible, is quite an incision to choose the index procedure. Thank you very much for your attention.
Okay, thank you. Maybe we can have one short question. Simon, do you have one?
Yes, so very frank, thank you very much for this very comprehensive overview and excellent talk. Thank you, Professor Kentaro. And what do you think we are lacking in this journey, like patient's journey, but a physician journey as well? So there's something still unsettled, for example, conduction abnormalities, and the fact that we cannot take away the leaflets, which is different from surgeries, always pose problems like coronary obstructions, restricted leaflet expansion. So these are the things that I think maybe there's something they can still do more. What is your viewpoint on this?
Actually, the major difference between surgical procedure and TAVI procedure is because the surgeon can cut the leaflet and remove it from the patient body. But for transcatheter procedure, we cannot do that. It might lead to the neo sinus, and it might lead to the sinus sequestration or the potential the TAV in TAV coronary obstruction in the future. So I think that if the patient has the quite spacious sinus of Valsalva and the repeat procedure feasible, we can choose the transcatheter procedure from the first procedure. And if it's not feasible, maybe we can think about the surgical procedure as the index procedure, and then so we can think about the future TAV in TAV procedure.
So for me, for example, I can imagine like 5 but 10 years later, we'll be in this session, we're talking about TAV in TAV in TAV. Then there's nothing you can do, even you have the shotgun, everything, extra cut, everything. So the problem still exists because we are moving to younger age, and I think we can do something a little bit earlier on to prevent things from happening. So I think we have to work hard together and we learn from experience.
Definitely.
Thank you.
Thank you.
Okay, next I would like to ask Simon to chair the next three lectures.
Sure, my pleasure. So the next talk is by Dr. James McCarthy, and he's from University of Washington in Seattle. And his talk is about alternative access for TAVI, which is a very important topic as well. So thank you very much and welcome to Taipei Valve.
Thank you for having me. It's a real honor. Hopefully you can hear me okay?
Yes, yes.
Good. Okay. Share my screen here and okay. By the way, just on the point of the last conversation, we have a company that is called Excision Medical to fully cut out the leaflets. And we have a temporary valve that you can put in underneath the prosthesis, underneath the TAVR, so you can cut all the leaflets out without having hemodynamic shock and then put a new TAVI in. So hopefully in the next year or two, we'll have some hopefully next year we'll have our first in man and be able to explore that more. In any event, today I'd like to speak a little bit about alternative access for TAVR. My name is Jamie McCabe. I work at University of Washington in Seattle, the United States, and I'm a real honor to be here with you today. The objectives were to talk about the indications and options for alternative access in TAVI, and also importantly discuss limitations and pitfalls of those options, and then just a little bit of tips and tricks in case there are things that you are routinely doing. So alternative access is really any access other than percutaneous femoral access, and the options include percutaneous options and surgical exposure in the TAVI space. The percutaneous options are axillary and transcaval, facilitated femoral, which we'll get into briefly. On the surgical side, you can do direct aortic and LV apical and carotid. You could also do axillary with surgical exposure. So a lot of this is driven by what experiences each hospital has and what they feel good about. There are no randomized control data to compare one technique to the other. There are some observational data, particularly in the United States, looking at the TVT registry, that are somewhat retrospective. So a lot of the decisions end up being kind of heart team or patient specific. And I think that's very reasonable in the absence of randomized controlled data. So I'm not going to spend too much time on direct aortic or transapical access. I'm not a surgeon. I don't do those. I will say that in the US, it is becoming very uncommon. As of 2019, which is now 5 years ago, it was 17% of all alternative access. I think that number is now down below 5%, though I don't know the exact numbers at this point. It was also the predominant mechanism for transcatheter mitral valve replacement, and even that is shifting now. Of course, Tendyne still requires transapical access, but the other devices have all gone transeptal. So this is a technique that is not relatively common any longer. Carotid access has been very popular, at least in the United States. As of 2019, it was 20% of all alternative access in TAVI, but because of some very positive observational data about stroke risk, it has really become sort of a popular choice in the US. It's typically surgical exposure and closure, and screening is the screening that tends to be important is making sure that the other carotid, not the one you plan to access, does not have significant disease, because you are sort of counting on flow through the circle of Willis via the other carotid. So you tend to perform this procedure on the least healthy of the carotid arteries, leaving the healthier one to supply the brain. Axillary access is, and we'll go into all of these a little bit more in detail, but just as an overview, we've published data suggesting that both percutaneous access and surgical exposure have equivalent outcomes, with the exception of a couple small things like time in the hospital is a little bit longer with surgical exposure, as you might expect, but otherwise the outcomes are equivalent. It was a very popular access point, at least in the United States. Over half of all alternative access 5 years ago. It's probably gone down in favor of carotid because there was this sort of observational signal of increased stroke risk with some data that we've published and others have published. It's a nice, if for indwelling devices, not TAVI, but say circulatory support pumps, it is nice that people can be mobile with this device in place, but that is less important in the TAVI world. Transcaval access, which you may be familiar with, is a crossover technique where you start from the percutaneous access from the femoral vein and then cross from the IVC to the abdominal aorta. Tend to focus on an area between roughly vertebral bodies L3 to L5, which represents about 1 inch below the renal arteries to 1 inch above the aortic bifurcation, so that if there is a problem and a stent is required, a covered stent would not cover the renal arteries or the bifurcation. So that's where you tend to focus in that area. The real advantage of transcaval access is that it does require the largest, it does allow for the largest sheath implantation since you're really going directly into the aorta. It costs a little bit more money in terms of supplies because the closure device is off-label use of a plug, which costs some money. And one interesting thing is that there's a 0% complication rate with that plug over time that is proven by CT scans at 1 year. So that I wasn't sure if that was going to be the case, but it does appear to be quite favorable in that regard. And then just a brief word on sort of facilitated femoral access. Shockwave or lithotripsy have become very popular, and trying to be more aggressive about standard femoral access using lithotripsy or balloon angioplasty plus or minus stenting certainly is something that's becoming more commonly done. There aren't any data to compare it to other to compare it to other alternative access sites. So that's something that we don't really know very much about, but it certainly is a familiar access technique. So that I think is an advantage. Just a couple of tips and tricks on each of them. So from the axillary perspective, typically you're targeting around between the first and second segment of the axillary artery, and the needle will pierce through pec minor. Therefore, after closure, these patients can get a little bit swollen in their chest. It is not necessarily hematoma. It's just that the muscle becomes edematous. So when we do this, we always ask the nurse to put an ice pack on the shoulder to keep down some of the swelling so that someone doesn't mistakenly think that there's a growing hematoma there. That area between the first and second segment is the area where the brachial plexus is a discrete bundle, meaning that it is all by itself over there and not a web, so that you don't worry about damaging the brachial plexus with the needle. So this is the axillary artery, obviously coming out from underneath the subclavian vein in this cadaver model, but the brachial plexus is just cranial to that spot. Okay. A couple other quick points. If you're going to do this from a left-sided access perspective, I think the one trick is to put the screens that you might look at up by the head, looking down towards the feet. Classically, as I go to proctor this, nurses will take the screens and put them by the feet, which is a very difficult place to orient because you have to look backwards to see that, and that becomes a little bit challenging. So our room setup is like this, with the screens, as you can see, up towards the head, looking down, and that allows you to look directly at them as you're working from the left shoulder. So if you do that, I think that's one simple little trick to do. The other point that I get called about a lot is that it is important to understand that if you are going to do percutaneous axillary access, there are bony structures both anterior and posterior to that artery. And therefore, the needle puncture needs to be very shallow to the skin so that the transition of the plastic catheter that you plan to put in doesn't have to make a sharp bend as it goes underneath the clavicle and above the second rib, right? So a very shallow stick is very important in these access, and because you can kink the sheath. So it looks somewhat similar to this, so that the trajectory of the sheath goes in a straight line. Other quick points, I think it is important to take an angiogram, if possible, from the leg of the artery that you plan to go down. Even put a wire down there so that you can understand the whole trajectory, and then use ultrasound to see the wire, confirm you are where you want to be, and that can be very helpful. From a closure perspective, we published the ARMS data. This was Impella-related information, but essentially little bits of oozing can create external compression on the on the brachial plexus that can cause some numbing in the fingers, particularly in C8. That was the primary complaint for indwelling Impella catheters in the axillary artery. So we tend to do these with dry field closure so that they're as clean as possible. Manual compression is possible. The axillary artery runs over the second rib. So you can put, if your closure does not work, it is very feasible to do manual pressure of this axillary artery. You just put your hand right underneath the clavicle and push there, and that will push down on the second rib. On the transcaval access, obviously this is the IVC crossing over into the aorta. CT screening is very important in the beginning. You want to just roll through a CT scan and look for a spot where the where the aorta, the wall facing the IVC here, is not calcified, and then mark that relative to a vertebral body, so that when you're on fluoro, you can know, okay, I want my axis to be at the bottom of L3, and because that's where you're following the body on the CT scan, and then you see where the axis is most favorable. After that point, once you have your target in mind, you're going to electrify a wire to cross over into the aorta, and then snare that wire and deliver it forward, so that then catheters, plastic catheters, both an 014 and an 035 catheter, can be brought into the aorta. And then a Lunderquist wire, a very stiff wire, is then advanced from the IVC into the aorta to straighten out that connection, and then a sheath can be brought forward. There are many resources available on this. Obviously, it's hard to learn it in just a few minutes, but if you haven't had the opportunity to try this before, there certainly are tutorials, both written and video. As I mentioned, 0% late complications, which is very favorable. In the early trial, which I was a part of, we did not use protamine on closure, which is a mistake, and we now reverse the heparin with protamine before closure. We have historically not done cut downs of the carotid artery because of radiation exposure to the operators, though I think it has become a kind of a favorable environment just because of its data. And so I want to point out that we now have actually performed multiple percutaneous carotid TAVIs and published on this. It turns out to not be particularly challenging. Like the axillary, we put a wire up and then stick a needle using ultrasound to the wire. We leave a balloon wedge catheter up in the distal to the sheath that we put on, and then keep the balloon up because that keeps any debris from going up to the brain. Then you put your sheath in this way through the skin and through the carotid, do your TAVI, and then all while the balloon is up, and then you can close your PER closes and then pull the balloon down like a Fogarty balloon to pull out any debris into the aorta. And so we've published a series of case reports on this and have done it not a ton of times, but maybe a dozen times now with no strokes so far. So in conclusion, there are multiple possibilities for alternative access. I think each hospital chooses what works best for them. Fewer and fewer cases require alternative access because the delivery systems are getting smaller. We're getting better at TAVI. Being able to balloon or use lithotripsy in the legs has become very favorable. So I don't know that people are still learning many alternative access techniques, but certainly it can be very helpful in select cases. So thank you very much for this invitation and your time.
Thank you very much for this excellent talk. And we know that that the need for alternative access is getting less, but it really a portion of patients really need that. And but sometimes when we think about, for example, transcaval, because we don't have that volume to train, because even for transcarotid, even for accessories, or even previously transapical access for surgeons, they need a number, and then they need to, it's not just like anatomically we know how to do it, we can do it. It's need to be like maintaining a certain volume and to minimize the risk. So when this number is getting less, so how would you choose? Or you stick to the next access, or you only stick with one alternative access, so that we can be very experienced on that? And what is the kind of thing that is happening in US? Is it individual center difference, something like that?
I think that's a very smart point. There are certain centers that where the volume suggests that they can do many different alternative access. And at my center, we do percutaneous carotid, percutaneous axillary, and transcaval. We don't really do any LV direct apical TAVI, but we do the other three. I think but we also do 600 TAVI a year, and I get a lot of referrals specifically for that problem. I think there are lots of centers in the U.S. who do about maybe 100 TAVI a year and probably don't do any alternative access, and usually sort of refer them locally in kind of a hub and spoke model where there's one big center and then many other centers who do a somewhat fewer. We'll see. I agree that the experience is that it's hard to maintain experience, and if you don't do one every 3 or 4 months, it can be very challenging to remain good at it.
Yeah, so thank you. Here's a quick question for Japan experts. So what is the most common alternative access that's been used in Japan?
Yes, actually, so we do almost 98% from transfemoral. So and most so preferable is so far subclavian artery, axillary artery. But from this April, we could start transcarotid artery procedure, but less than 20 cases so far in Japan. So actually, we want to know how to prevent stroke by transcarotid, or how to prevent other complications. So we don't have so much experience about transcarotid. So do you have any tips or tricks?
Well, for most centers, it is cut down and having either a vascular surgeon who does endarterectomy and can loop the carotid is very helpful. A lot of cardiologists really enjoy the carotid access because they get to come in at the end, just put the valve in and then walk out, and it's very quick for them, and the surgeon does all the work. I don't enjoy that as much. I prefer to do all the work myself, and we have had a good team with the percutaneous access, but I know that I don't know that any other centers have done percutaneous carotid yet, so that's kind of a newer thing. And the people who do a lot of carotid access really, I don't know. The surgeons do it, so I don't really know all the things they do.
Right. So thank you very much once again for this excellent talk, and enjoy the discussion as well. Thank you very much. So next we have the next topic on Redo-TAVR in bicuspid aortic stenosis patients from Dr. Radosław Palmer from Poland. So welcome to Taipei Valve.
Thank you so much, and good morning. It's 5 a.m. in Poland, and also first, I'm very happy to join you. I was also listening carefully to the previous talk because we are a large volume transcarotid center in Katowice in Poland. We've done more than 150 transcarotid cases, and one of the tricks I can say is that we try to use balloon expandable devices using commander system of SAPIEN to facilitate actually the valve crossing and to skip the predilatation. So this is one of the first tricks. Also, the deflection of the system helps us to guide through bicuspid aortic valves. It's quite straightforward procedure. We do it with a surgical cut down still because of the vein overlap over the carotid artery. So this is our reservation for going percutaneous, although we would love to do it. And then just to be prepared for 2 inflations like double tap technique for SAPIEN, because many of these bicuspid patients are not expanded fully. The only problem, just a trick, is when there is a balloon burst, and then the retrieval of this balloon becomes problematic through the transcarotid route. So very happy to share from Poland. Also, I was listening to the previous talk and hope to discuss it in the future, maybe in Taipei.
Yeah, sure. Thanks.
So And now I would love to share my screen for the Redo, which is in the center of our interest in here in Europe, especially also that there will be patients who will be young patients, often with bicuspid aortic valves. The bicuspid valve is more prone to distortion of the frame of the TAVI device, and probably earlier degeneration, as you can see on the right. So what is actually a mainstay of every preparation for the Redo in bicuspid anatomy, but also for any Redo, is the careful CT analysis, the assessment of the THV, the aortic root, and also the Redo-TAVR support if we can fuse the imaging with a fluoroscopy. So the procedural recommendations for Redo has been published by our group in Europe by Professor Tarantini, also with a checklist for pre-procedural screening, which is mainly based on the CT, and there is a consensus that we should not skip CT in any way, preparing for the Redo intervention. And also, as you can see on the top right, there is a recent app available in the iOS and Google Store systems, which helps guidance on Redo-TAVR procedures, created by Dr. Fukui and Professor Vini Bapat, which actually also shows the data which we collected also in our European practice. It is extremely important to know all diameters and dimensions of the previous device. The reason is that especially for the waist part of self-expandable devices, we need to know what is the limit of the expansion of the second device. The thing is that it is the waist which is most restrictive for the anatomy of the device. And then on top of that, there is a restrictive force from the bicuspid leaflets around, limiting the expansion of the second device. So as you can see, for the core valve, which were the oldest devices implanted in Europe, the waist is 23 to 24 for the largest 31 valve, while it is 22 to 24 for the smaller devices of the core valve. In theory, we can destroy it, and we are exercising it with non-compliant balloons like Atlas or through dilation balloons, to destroy the leaflet suturing and also to destroy the skirt suturing in Evolut R devices and any self-expandable devices which have the suturing and also the skirt of the device. You can also see that for Evolut R, the waist is 20 to 24 millimeters. However, we can try to deliver 26 or 29 sapien inside to overexpand this device, but it should be done after the predilation with a non-compliant balloon of, say, 26 millimeter for Evolut R or 28 millimeter for Evolut R 34, if it is safe considering the anatomy of the patient. So also what we need to learn for discussing about the height of the implantation is how we decide on the implantation side. This is the calculation. This is one of the methods to do it, is to count the nodes of the device, counting from the bottom. And as you can see, the leaflets end at the node 7, and the suturing of the leaflets ends at the node 5. What I usually do also while we decide on the site of implantation is to count from the top, like 2 large cells from the top is node 6, or 3 large nodes from the large cells from the top is node 4. So it is much easier to see during the intervention. What we also realized is that in patients who have been treated with Sapien XT, it's not only that we need to take into consideration that the inner diameter of the device is smaller than the outer label diameter of the device, but also for the Sapien XT, there is a flaring of the top of the prosthesis towards the coronary ostia, which limits the distance of valve to coronary and may actually may cause the the leaflet of the bicuspid valve be moved towards the coronary ostia, probably risking the coronary closure if the VTC is smaller than, say, 4 millimeters. So this is especially true for SAPIEN XT, which has a flaring of the top because of the significant volume of the suturing against the post of the valve. It is not this flaring is not present in the SAPIEN 3 Ultra. However, we know that the possibility of overexpanding the SAPIEN 3 Ultra is only 1 to 2 millimeters maximal from the label diameter, and also that we should know that after several years there is a lot of fibrosis around. So this overdilatation may be only possible in case there is a free space around, like from a paravalvular leak, which lets us overexpand this valve before implantation of the other one. The identification of the first device may be facilitated by what I just prepared for you, is counting the nodes on the CT. So what I do is, you can start from the right. This is the SAPIEN XT. What I know is that there are 12 nodes starting from the bottom from the SAPIEN XT, and also present at the SAPIEN 3, because the only difference here is from the bottom is only the presence of the skirt. But it is especially for the self-expandable systems, sometimes we cannot distinguish between them, judging only from the CT if this is of lower quality. So we know that there are 15 nodes from the Evolut R, and also that Evolut FX just recently introduced in Europe, and much earlier on introduced in the US, has radio-opaque markers counting if we see it from the inflow. So this makes provides additional support in identification of the valve. The Navitor, which is the Navitor system from Abbott, has 9 nodes counting from the bottom. As you can see, the frame of this device in bicuspid anatomy, for which it is not registered in Europe, may be quite constrained, and so then the overexpansion with a non-compliant balloon first before Redo-TAVR would be crucial to optimize its diameter. This is the accurate Neo, which has 15 nodes counting from the bottom, but because of very characteristic, very unique frame structure, everybody knows how it looks like. However, this inflow segment, if we need to treat it in this region, because usually we implant the second device in the crown of the Navitor, is important to judge the asymmetricity of this valve. The Lotus system used to be implanted in many of bicuspid patients in Europe, because this device had the strongest radial force for opening of the bicuspid heavily calcified bicuspid anatomies. So it cannot be overdilated. However, I saw Professor Nicolas van Michem and also French centers doing Redo-TAVR interventions in this prosthesis. Also, what we need to know is actually to judge the risk plane, which is the highest position of the opened leaflets after Redo-TAVR implantation. And we should also take into consideration that in the most common type 1 bicuspid anatomy, the 2 leaflets may be deflected towards the LCA and also towards the LCA, risking the coronary occlusion. So we should analyze the distance from the frame, and it is not from the middle of the frame. It should be probably from the internal part of the frame where the leaflets are, where the leaflets of the second device, of the first device, are located, to the LCA. And as you can see on the left, there is this fused leaflet from the left and right may be deflected towards the LCA, leading to coronary closure during the intervention. This slide I wanted to show with you because this is a direct flow prosthesis, which is a valve which was inflated by a polymer injected into the frame of this prosthesis. It was withdrawn from use in 2016. However, in bicuspid anatomies, this is quite rare to see it, but bicuspid anatomies caused a lot of restriction to this valve because of unequal expansion. The problem with this frame is that with a polymer, after so many years, bench tests showed that the overinflation of this device with a balloon and another device may cause the rupture of the surface of this device and polymer exposure to the blood. So this is why we see only single numbers of Redo-TAVR implants in these patients in Europe. However, we should be careful in overexpanding the frame, because we don't know whether this debris of the polymer may be released to the blood and also to the brain. So this is the VTC, which I already showed you. The average consensus is that we should try to protect any patient with a VTC, valve to coronary, of less than 4 millimeters. However, in large, it is good to refer to the native anatomy of the bicuspid. In large leaflets with a long fusion, long graphy, I advise always to protect the left main with a stent positioned in the LAD or LCX, just to avoid the closure. So I was just this is the commissural alignment, which should be also optimized for the bicuspid. However, it is in type 1, the fusion of the two leaflets make it less possible to re-enter the coronary if there is an overlap of the fused leaflet against the left main. The assessment of the leaflets is important, because what we saw in our cohort is that bicuspid patients are way more prone to the hypoattenuation of the leaflets and probably of the leaflet thrombosis. It may be intrinsic to the biochemistry, or so, because we know that patients, it is not only that there's a geometrical difference in bicuspid patients, but also in young patients, there is a different reaction and composition of the calcification, and also the more probability of the thrombosis. But what we always look is the presence of HALT, and if there is any HALT present, then it may be that we may need to skip the predilatation with a non-compliant balloon, or we consider strongly the protection of the carotid arteries. This protection, although it was not shown in randomized clinical trials that for a native valve TAVI, the protection works in bicuspid anatomies, we think that for redo, and for sure with a HALT present, this protection should be used if the center has experience in using them. So this is these are the bicuspid patients, as you can see from our cohorts of patients with the degenerated prosthesis. These are the non-uniformly expanded bicuspid patients with SAPIEN 3. And this is why we try to optimize more and more the bicuspid implantations, the SAPIEN 3 and bicuspid implantations, by post-dilatation of the SAPIEN as much as possible. Because in this unequal expansion of the SAPIEN, we see this HALT very often leading to peripheral emboli. And this is also how it looks like from other projections in other patients, making us more doing Redo-TAVR in these patients. But we also noted that SAPIENs are either of smaller size than nominal size, so underdilated, or they are asymmetrical. And also, I would just say that this kind of asymmetry we see a lot in bicuspid patients, leading to early HALT. And although HALT itself is not connected strongly to the stroke, we see many, like positively, we see many patients with a peripheral emboli, and always check them with a CT for the presence of HALT and the need for reoperation. Heparin, of course, is given first just to try to get rid of this thrombosis, but then we are trying to do Redo-TAVR in them. This is the kind of asymmetry in bicuspid anatomy which I already showed you with a direct flow device, and this is also difficult to predict where to implant the second device, probably trying to target the bottom. But this also shows you how unpredictable the final outcome of the redo will be when we target these patients with a heavy force of the calcium of the raphe in bicuspid patients. This is also the example of one of our patients with accurate neo implanted in bicuspid anatomy. You can see the inflow of the heavily restricted crown with the average diameter of 17, although this patient had an annulus of 23. And then we need to probably predilate with a non-compliant balloon to try to open this region of the crown, and only after that implant the second device. The implantation projections are extremely important to, first, to distinguish between the projection which shows us the risk of the occlusion of the left main, which you can see from the left. This is usually on the right, which is usually the LAO cranial, which we know from the PCI of the left main. And the second projection is to understand the position of the raphe, meaning that the raphe should be externalized to see the final expansion of the prosthesis in the most limited region. So we usually use two projections. The first one is the projection to externalize the left main, and the second one is to externalize the largest volume of either two leaflets or the raphe calcified spot to know the limitations of the expansion of the second device. As for device choice, I think that balloon expandable SAPIEN system is the best system to target any previous valves, because it matches all balloon expandable and self-expandable devices. In our consensus, European consensus, we advise to do balloon expandable for using the same size of the device if the first SAPIEN is not of a very small diameter after the bicuspid implant. We may try to optimize it and only then implant the second device. The reason for optimization before Redo-TAVR is that once we implant the metal to metal, it's more difficult to post-dilate with a non-compliant balloon than before. For Lotus, so mechanically expanded devices, we also use balloon expandable devices here because SAPIEN is the only one registered in Europe for Redo-TAVR. You could theoretically use other self-expandable systems, which is also possible. However, we need to note that there may be troubles in coronary access in these patients. So this is why the first line would be to use balloon expandable in mechanically expandable devices. For any self-expandable device, the short frame balloon expandable will be optimal. Any other self-expandable device will limit the coronary access and also probably will be of less radial force. So this is why the balloon expandable may be probably better to fully open the frame and then prevent the frame recoil in bicuspid anatomies. Also for self-expandable like accurate neo, but trying to target low. For the simulation of the Redo-TAVR, what we do is we are trying to simulate on CT the crimped device or crimped self-expandable device, and also to try to understand how to position it against coronary ostia. Usually, the top of the frame is positioned at the level of the RCA or LCA, whichever is lower, and then we follow with the implantation. We need to be careful, however, because in bicuspid anatomy, the waist may be very narrow, and during the commander balloon inflation, the LVOT part inflates first, trying to pull, and it is actually pulling the device towards the LV. And this is one of the most frequent problems I see in Redo-TAVR intervention when we proctor them or we do observe them in our Redo-TAVR registry, is that this device is too deeply implanted because of this move towards the LV, because of the balloon inflation from the LVOT first. So it's much less often that the device goes too high. It may happen only with the LV pressure, pushing on the valve during the final stage of implant. Usually it is too low. So please be careful when we implant in the waist of the bicuspid patient. We should try to optimize it with a balloon first, and then only to implant the second device with a very slow implantation. So this is how the root scan also looks like while trying to prepare for this bicuspid implant. And we are also trying to understand how much risk for the coronary obstruction there is. Also to note the position of the raphe in these patients. So this is for self-expandable patients, also mimicking what we will see on the fluoroscopy on the Three-Mentio in the top middle mirror. And this is one of the examples of the high implant at the node, probably reaching node 6 in this patient after the pre-dilatation. And as you can see also that this patient has a low position of the first valve implantation. It is a core valve, which was too deeply implanted, and also with a paravalvular leak around the skirt. The positioning of this of the second device should target first that it seals the annulus, and then also that it treats the generated valves. So this is why, in theory, it is implanted way high in the evolute in the core valve system. However, we should always try to understand whether there is a too deep implantation where we need to seal also the region of the aortic annulus. So what we also are trying to do in our center, I only will stop this, is to support the Redo-TAVR now with a holography. We use HoloLens system and trying to prepare for the Apple Vision glasses, where we are trying to fuse the image of the aortic root with a previous device. And by doing this, we are trying to see actually the positioning of the raphe and also the positioning of the left main in our patients undergoing this intervention. And the final note will be that bicuspid patients are not the part of any randomized trial in native anatomy, but also they are not observed for Redo-TAVR interventions. We are doing now the registry for Redo-TAVR, where we observe all the outcomes of all observations prospectively, including bicuspid patients. And because I strongly believe that these will be bicuspid patients who will undergo the Redo-TAVR interventions most often, because bicuspid patients are the future of the TAVR implants and they will live longer. So this is why it's extremely important not only to know the outcome of the first redo, but also the outcome of the second or third redo in these patients. So we would be very happy to cooperate with you and to know your experience, and are very willing to connect for exchange of the practice. Thank you.
So thank you very much for this very exciting lecture, and really a lot of new things, technologies that could help plan our procedure. And I think is highlighted is sometimes because of the original bicuspid anatomy, it restricts the optimal results, expansion, decreased volume. And if you do the second one, you have to make sure you don't follow the first step. You have to optimize the first one and then go, just make sure this implant is optimized. Otherwise, you will need to degeneration again. But the problem is sometimes for bicuspid, there must be a reason for that suboptimal expansion. Maybe perhaps it's due to previous older generation of devices, but maybe of calcium, restricted raphe, and it's really a very hard time sometimes to figure out. Maybe we go back to the first CT, really there's no margin for us to expand further. So I think it's a very important topic. So thank you very much for this excellent talk, and this also leads to the next lecture. So let's give applause to this lecture. Thank you. Okay, so the next talk is about anti-platelet or anti-coagulation of TAVRs. We heard about the issue on the halt, and that actually links very strongly to about prosthetic failure and degeneration. So we're happy to have Dr. Sherwood Matthew to share with us his view on this topic. So welcome to Taipei Valve.
Thank you very much. Give me one moment. I'm just trying to find a way to share this screen. Here we go. Can everybody see that?
Yes, very clearly.
Very good. Well, again, thank you so much for inviting me. I'd love to talk about this topic, which I think has gained a little bit more clarity in the past few years with some studies. And I just wanted to quickly comment. I thought that the previous talk to mine was fascinating and really important in thinking about Redo-TAVR, and a couple of talks before that about lifetime management. We're a little bit fortunate in the United States. I'm from Inova Heart and Vascular Institute near Washington, D.C., and we have access to the Medtronic CoreValve FX Plus, which actually has large fenestrations in it. 3 large fenestrations where the coronary ostia might be, and it allows you with commissural alignment to actually have a very large window into the coronaries. So if it's aligned, it actually helps both with the initial implant and procedure, but potentially for the next implant and procedure. So it's a very nice system, and I think it's something that may help with these decisions in the future. But I thought it was great. Some of the issues that we talked about in the last presentation with halts, et cetera, are why we have kind of these discussions about optimal antithrombotic therapy after TAVR. So there's limited data on what is the optimal therapy after TAVR, and most of the guidelines had previously been empirically based. Early recommendations were based on the pivotal clinical trials where dual antiplatelet therapy was used universally, but without any real evidence. The possibility of bioprosthetic valve thrombosis has created questions about the utility of antiplatelet versus anticoagulant medications, and unanswered questions remain in the population of patients who undergo TAVR who have pre-existent atrial fibrillation. And early on, that was 30 to 40% of patients. Now I think it's a few less patients, at least with younger patients undergoing TAVR. So I just wanted to sprinkle in kind of real life patients that we've seen and questions that come up, and I hope to answer these questions during the talk. This is a good example, a 78-year-old male with hypertension, PAD, coronary artery disease, and PCI in the distant past, as well as GI bleeding, who was referred for TAVR. His primary cardiologist had actually gotten a genotype test to show that he was an intermediate metabolizer for clopidogrel. And the question would be, what antithrombotic therapy would you prescribe after an uncomplicated TAVR? And I hope at the end of our talk, this question will be easier to answer. So here's just and I apologize, this is the American guidelines for antithrombotic therapy after prosthetic valves. And specifically, I've cut and pasted the indications. There are only 3 that mention TAVI specifically. And the first is that for patients with a bioprosthetic TAVI, low-dose aspirin should be used if there's no other indications for oral anticoagulation. The second is that for patients with a bioprosthetic TAVI who are low risk for bleeding, then you can consider using dual antiplatelet therapy with low-dose aspirin and clopidogrel for 3 to 6 months after valve implantation. And the final one is a negative one, and that is to say that for patients with bioprosthetic TAVI, you actually treatment with a low-dose rivaroxaban, in this case plus aspirin, is contraindicated unless there are indications for oral anticoagulants, and we'll see why that is the case in a couple of trials that have indicated that low-dose direct-acting oral anticoagulants are not the answer to our problems. So we actually published a paper in 2018 in the American Heart Journal indicating how much hospital-level variation there is to the use of antiplatelet therapy in patients who undergo TAVR without an indication for oral anticoagulation. And here you can see from data from 2011 to 2016 in 15,000 patients, the majority of centers discharge, 70 to 90% of their patients on dual antiplatelet therapy, but there's still a good number of centers that use dual antiplatelet therapy less than 50% of the time. And so there's a lot of variation to what is done because the evidence may not be as clear. Now, there was a very small randomized clinical trial called ART in 2017, which randomized 222 patients who were undergoing TAVR without an indication for oral anticoagulation to aspirin or aspirin plus Plavix for 3 months. And as you can see, the numbers are very small, about 100 patients in each arm. But what we saw were similarly low rates of stroke and TIA or MI for patients on either aspirin plus clopidogrel or aspirin alone. But certainly the patients on dual antiplatelet therapy had higher rates of major bleeding. And this has led some in the United States, for example, to think about using just single antiplatelet therapy after TAVR. Well, enter the popular TAVI trial, and in addition to this, the Atlantis trial, that actually are much larger, but they're kind of 2x2 factorial trials, looking at both the question of antiplatelet therapy and oral anticoagulant therapy. So we'll first talk about cohort A here from the popular TAVI trial, where no oral anticoagulant was indicated and it was randomized 1-to-1 to either aspirin or aspirin plus clopidogrel. You can see that the primary endpoints were mostly bleeding and some ischemic endpoints in the secondary. So here's cohort A, and that is randomizing about 690 patients to aspirin alone versus aspirin plus clopidogrel and follow up for 1 year. And what you can see is that certainly dual antiplatelet therapy is associated with more bleeding, 26.6% at 1 year of follow-up versus 15.1% for the aspirin alone group. When you look at the results of the ischemic endpoints, and so on the right-hand side of the slide, you can see the ischemic endpoint alone. There was no difference really in the ischemic endpoints for dual antiplatelet therapy versus single antiplatelet therapy. And for the net clinical benefit endpoint, certainly there's benefit to aspirin alone, mostly driven by the fact that there's lower rates of bleeding. And so their message takeaway from that is that perhaps aspirin alone after TAVI could be used because it reduces bleeding events significantly and does not significantly increase the rate of thromboembolic events. And so in patients who don't have another indication for dual antiplatelet therapy, it's certainly reasonable to use aspirin alone. The issue became this specter of bioprosthetic valve thrombosis, and I appreciate that we've already talked a little bit about HALT, et cetera. And in 2015, Raj Makkar published the first data indicating that HALT was maybe a significant problem for TAVR valves. And since then, we've looked at the Resolve and Savory registries located in the United States and in Europe. And what you can see is 931 patients undergoing either TAVR or SAVR with CTs afterward, really to look for prospectively HALT. And what you can see is that, it's really important to know that both dual antiplatelet therapy and mono antiplatelet therapy do not prevent the presence of HALT. And so you can see the presence of HALT was about 15%, whether you took dual antiplatelet therapy or mono antiplatelet therapy. If you have an indication for oral anticoagulation, then the rates of HALT were much, much, much less. What they did find, though, was that if you did have a HALT, then if you continued DAPT afterward, there was really no resolution. But if you started oral anticoagulation therapy, either with a vitamin K antagonist like warfarin or with direct-acting oral anticoagulants like rivaroxaban, apixaban, or dabigatran, there's a lot more rivaroxaban and apixaban used in the United States, then you did see resolution over time. So good indications that oral anticoagulation does, in fact, result in less HALT, and the treatment for HALT would be oral anticoagulants, and unfortunately, antiplatelet therapy doesn't have any effect. So this led to the theories of whether or not, what is the antiplatelet hypothesis? Why do we use antiplatelets after TAVR? Really to obviate the risk of platelet-related thrombosis and embolization phenomena. Or the antithrombin hypothesis is why do we use anticoagulants after TAVR? Really, it's to halt any thrombin-mediated formation. And so a very nice clinical trial was done called Galileo to study whether or not low-dose direct-acting oral anticoagulant would be helpful for patients undergoing TAVR who did not have an indication for full-dose oral anticoagulation. And this is, done and published in the New England Journal. Here they randomized 1,500 patients 1-to-1 to either dual antiplatelet therapy right after TAVR, or rivaroxaban plus aspirin after TAVR for 3 months. And then they drop down in the rivaroxaban group to rivaroxaban low dose alone versus aspirin alone in the other group. So, and I do want to note that this is rivaroxaban 10 milligrams, not a dose that we actually have any approval for in the United States for any other indication. And what you can see here is the primary efficacy endpoint, and that is time to death, stroke, MI, valve thrombosis, pulmonary embolism, or systemic embolism. And here, amazingly, you see that the rivaroxaban arm actually performed worse than the antiplatelet arm. And remember, this is a low-dose rivaroxaban. And for bleeding, as you might expect, the rivaroxaban arm also still performed worse than the antiplatelet arm, resulting in an increased risk of bleeding. So, what we conclude from that is that, there's really, in patients without an indication for oral anticoagulation, there's really not any evidence to suggest that using low-dose rivaroxaban would be helpful for patients. It results in no decrement in bleeding, and unfortunately seems to be linked to more thromboembolic events afterward. So that's where that third recommendation from the US guidelines come from. What about patients who actually need oral anticoagulation? And again, this is another study we did and published in Circulation Intervention for 26,000 patients who were undergoing TAVR, who actually may have had prior atrial fibrillation or flutter or did not. And here you can see 44% of patients actually had prior atrial arrhythmia that required oral anticoagulation. And when you compare the adjusted outcomes of atrial fibrillation patients versus non-atrial arrhythmia patients, you can see that it's actually much more likely that these patients have mortality or bleeding, mostly because they're on anticoagulation, as compared with those patients who do not have atrial arrhythmia. So this is something serious and predicts both morbidity and mortality for TAVR patients. The problem was that the practice patterns in the United States, at least in 11,000 patients, were very, very variable. And so here you can see for patients who were discharged on just one agent alone, if they were discharged on oral anticoagulation alone, it was typically warfarin with a smaller dose of dual direct-acting oral anticoagulant. If they were discharged on antiplatelet alone, it was most often dual antiplatelet therapy in 71% of patients. But here's where a lot of the kind of the variability comes in. If they were discharged on a combination of things, then you can see there's, no less than 10 different ways that patients were discharged, and that is the vast majority on warfarin plus aspirin. But there are all these different combinations of dual therapy, triple therapy, etc., and without any evidence to indicate what would be the right technique. And so this is where, thankfully, new data has come in. So this brought me to my second patient, an 80-year-old woman, hypertension, hyperlipidemia, also had coronary artery disease, but had a distant PCI, who had persistent AFib and came in on apixaban 5 milligrams BID. She did undergo a successful TAVR, but on discharge 2 days later, what antithrombotic medical regimen would we choose? And so these are just a few of the options that are possible. Dual therapy with warfarin and aspirin, triple therapy, dual therapy with apixaban and aspirin, or triple therapy, or would we consider DAPT alone or apixaban alone? So there's no help really from guidelines for TAVR in atrial fibrillation patients. This is not mentioned at all in our ACC-AHA guidelines. Canadian guidelines recommend simply that we avoid triple therapy, which seems to be consistent with PCI guidelines. Surgical guidelines recommend warfarin plus aspirin, and European guidelines, and this is a little bit older, but recommended at that time warfarin plus either aspirin or a P2Y12 agent. And thankfully, both Popular TAVI and Atlantis sought to answer some of these questions. So this is cohort B of Popular TAVI. It's much smaller than cohort A, about 300, a little over 300 patients who are randomized to oral anticoagulation alone versus oral anticoagulation with an antiplatelet agent. And here you can see about 3/4 of them who went on oral anticoagulation were on a vitamin K antagonist, a smaller percentage of patients, only a quarter on direct-acting oral anticoagulant. And what you can see is if you combined an oral anticoagulant with clopidogrel, then there was significantly more bleeding versus oral anticoagulant alone. And interestingly, if you looked at CV mortality, ischemic stroke, or MI, you know, there was not as significant savings if you were on oral anticoagulant plus clopidogrel. You know, even numerically, there might be more CV mortality, ischemic stroke, or MI. So in this case, from the popular TAVI cohort B, and again, this is a small cohort, but it established that, you know, it might be that oral anticoagulation alone reduces the rate of bleeding events and does not seem to increase the rate of thrombotic events. So really trying to simplify our lives in terms of how we make decisions around these complex patients. Atlantis was another trial, 1,500 patients. Again, 2 strata, stratum 1 that had an indication for oral anticoagulation, stratum 2 for those who did not. And here I'll just show you that when they looked at the overall cohort for patients with and without indications for oral anticoagulation, it seemed that apixaban was non-inferior to basically standard of care therapy. That is warfarin in the oral anticoagulation patients or DAPT in the no oral anticoagulation patients. When we look specifically at secondary outcomes, we can see that apixaban was associated with slightly less bioprosthetic valve thrombosis and other thrombotic outcomes, but really numerically less and not statistically significant. So outcomes in stratum 1, those patients who needed oral anticoagulation, again, about 200 patients in each arm, we can see, thankfully, that there was no significant difference between the standard of care, which was typically a vitamin K antagonist like warfarin versus apixaban. In stratum 2, we got, you know, interesting data to show us that apixaban in patients who did not have a need for oral anticoagulation did not perform very well as compared with dual antiplatelet therapy or even single antiplatelet therapy. You can see there's actually more thrombotic events, death, stroke, or TIA, or systemic embolism. And in terms of bleeding, pretty similar rates of bleeding. And valve thrombosis was a little bit less frequent with apixaban than dual antiplatelet therapy. So in this case, you know, what they thought was honestly that apixaban is reasonable to use alone in those patients who have a need for oral anticoagulation. But just like the Galileo trial, there's not really any indication to use a direct-acting oral anticoagulant in patients who do not have an indication for oral anticoagulants. So in conclusion, single antiplatelet therapy is reasonable in most patients without an indication for anticoagulation post-TAVR. So perhaps we can go with aspirin alone or clopidogrel alone in those patients. And those patients with an indication for DAPT or at low bleeding risk can consider DAPT for 3 to 6 months. In patients with atrial fibrillation or another indication for oral anticoagulation, you know, these days you could consider a direct-acting oral anticoagulant alone because it seems that that may be sufficient to reduce reduce ischemic events and may reduce your bleeding events as well. But you can add a single antiplatelet there if needed. So just to go back to our questions, again, this is question 1, this patient without a need for oral anticoagulation. In this case, because they'd had a previous GI bleed and most patients would qualify, I would pick aspirin alone in that patient. It seems reasonable now to use aspirin alone for patients post-TAVR who do not have an indication for oral anticoagulation, certainly in this patient who had high risk for GI bleeding. And in the second patient, 80-year-old woman who was at high risk for stroke with persistent AFib on apixaban BID. You know, certainly an 80-year-old woman with these comorbidities is probably at high risk for bleeding. So I think the data indicates that you could use apixaban alone in this patient to reduce the risk of bleeding, but would probably protect her from the ischemic events that might happen after TAVR. So I want to thank everybody for their attention and would be happy to take any questions.
So thank you very much. I think because of time limit, I have just a quick comment. So we are talking about more TAV in TAV now, and there's also anti-thrombotic issues, anticoagulation issues afterwards. And do we need to do all the study again for TAV in TAV or TAV in SALV? Because those patients will be more thrombotic or more metals there, more sinus illustrations, but they're sicker. Maybe they're older now. And so do you need, can you use the data that we have on hand now, or we need to repeat everything again?
No, I think you're right. Unfortunately, the Redo, either TAV and SAV or TAV and TAV, certainly are at higher risk for bioprosthetic valve thrombosis. We've seen that in registries, et cetera. And they may be at higher risk for ischemic events going forward. So I don't think that we have the answers to those more complex patients. those patients are typically higher risk for multiple events, given their age and their medical comorbidities that have required that they undergo redo aortic valve replacement. And so there are multiple reasons why those patients would be at higher risk. But I don't think we can apply the evidence that we have thus far to those patients.
Thank you so much. So I think we'll pass the time to Professor Yin, and is now going bring us straight to the live.
Yeah, you are also welcome to stay on the air. Let's go to the Zhejiang. Wang Suji.
Hi, good morning.
You are on the air.
Can you hear me?
Firstly, I would like to thank both of you rushed from New York back to Zhejiang for this live demonstration to support our meeting. Thank you very much.
I can hear you, but I cannot see you.
Yeah.
So, hi, good morning, all of panelists. Welcome you to the second affiliate hospital, Zhejiang University School of Medicine. Also, associate organizers to having us for the site of live demonstration. So, first, I would like to introduce my colleagues, Dr. Liu, nice to me, and also Dr. Hu and several fellows on my right. Also, today we have Dr. Lin for echocardiography, and also we have an anesthesiologist over there. So first, I would like to invite Dr. Liu to introduce the case to you. Please, Dr. Liu.
Okay, slide please. 幻灯切一下啊。Okay, good morning, everyone. So I'd like to share the case for you. Next one, please.
你把它放大。
Yeah, the patient is a 77 years old gentleman. The patient has very symptomatic, and the patient has a history of hypertension and a COPD. The echo showed the DMR for this patient. Next one. And from the echo, we can see the patient is a DMR from the A1 area. That's a very severe prolapse right there. And the EROA is about 0.65 centimeter square. And the LVF a little bit decreased. Next one. And this is the TE. You can see right here, very severe prolapse from the A1 area, and the regurgitation is severe. And the A1, P1, the leaflet length is about 1 centimeter from the P1, and A1 1.6 centimeter. And valve area is not so big, 4.7 centimeter square. Okay, next one. Next one, please. The coronary is okay. Next one. And this is the EKG. So for the strategy of this patient, so we'd like to use the TEER for this patient, and we will use the Dragonfly system. I think you know quite well. So we'd like to use, because the prolapse not to the C1, just focus in the area of A1. So we'd like to use one long and wide device. Next one, please. Okay, this is the Dragonfly system. There's some innovation of the clip system, can be closed at any angle, and then manipulate from the outside very precisely. It's easily for us to use it. Okay, this is for the case presentation. So any comments for the strategy?
Yeah, this is not an usual A2P2 regurgitation. So maybe we can ask the panelists and then the comment from you about the A1P1 approach.
So this is actually a A1 prolapse. The prolapse site is very close to the commisure, but not the true meaning of commisure region. So what is AI? Welcome your comments on the strategy, the size of the clip.
Please.
So welcome your comments.
How about the MBA? So how about the area of
4.7?
4.7, yeah.
So
Yes.
in that case, maybe we can choose. So we can't use Dragonfly in Japan, but if we use microclip system, so XTW will be suitable for this case, even very close to commercial side.
So in Hong Kong,
you mean the wider and the long, wider and the shorter one, or wider and the longer one?
Maybe wider and the long type.
Yeah.
So
Okay.
target is
But actually, if for the commercial region, regularly we select the wide and shorter one. But for this, because we have same consideration because the collapse site is not in the commercial, but very close to commercial, but we still select the wider and the longer one. So now we have we finished engagement in the sheath, the system in, and we already have the clip into the left ventricle. So now you can see the echo view.
Yes, very
echo
clear.
screen.
Simon, you want to comment?
Oh no, so for commercial clip, so maybe Professor Wang can just comment. Usually the orientation of the clip is crucial for grasping the leaflet, the frail or the prolapse at the commissure. They're not usually in the usual position, and sometimes M-TEER will help a lot because you really want to grasp it in one go, especially we like to use long clip because otherwise you don't want to manipulate too much with trapping of.
Yes, I fully agree with your comment. The multi-view may be very helpful. But problem is we're losing the high resolution. So I can show you could you show us the 3D and fast? So what do you think the orientation of the clip?
I think it's good.
Have you
tried
what we
clip?
need to do? Do we have further rotation, clockwise or counterclockwise, or the direction?
Just not already
Should be
below
okay.
the leaflets, right?
Yeah, already below. I think you can have a try.
Yes, now it's a little tough to grasp the anterior leaflets. So we try again. Yeah. Maybe a little bit more clockwise should be good, should be better. A little bit more clockwise, I think. Now it's almost 12 to 6 o'clock. We maybe want 12:30 to 6:30. So when we during our grasping the leaflet, we can simultaneously to judge the orientation.
Also, charging point is very high for the leaflet. It's just not on different plane. It's
So
quite mobile.
Actually the other challenges about the harking. Still think a little bit harking there. The posterior arm and the anterior arm not very parallel to the annulus line, to the annulus. So you can see that. So the anterior arm is a little bit lower than the posterior arm. So it's not very easy to grasp simultaneously.
So for the dragonfly, so can we do a similar maneuver to correct the aortic hugging so that we can change the trajectory?
Sure. And independently grasp. Yes, dragonfly has the function of independent grasp.
So maybe you grab the posterior leaflet first, and then the left.
太往靠门去切了，
可以拉高一点。拉高一点。后也在了。
Posterior is on.
前叶不在。
But
yes.
Not the anterior.
Not anterior, yes. So because the patient spine is tortuous for this patient. So during the atrial atom, the puncture is not so easy, and the aortic hug. Yeah, so maybe because of the anatomy.
我们再大一点看看。
对，它这
你还是要往你不要老往这个 commercial 去，我们现在可能太往 commercial。
这个脊柱侧弯啊，带来很多问题。
它往 commercial 太多了，所以我们看不到 leaflet， 我 only see the annular。
anterior，
我觉得还要调整这个 hugging。
那我们这后面已经打得非常多了，
打得非常多了啊，不能
已经打得非常多了。
或者再回来一点，把它关一点点。前面那次其实基本上已经找到了。
或者我们后叶先抓，前叶跳夹看看，前叶上去的时候再那个后叶已经在了哈。前叶它上去的时候我们夹一下看看。
我们稍微往下一点。
好，
你先看看 orientation。
multi
view 怎么样 ？multi view。multi view。你等下那个多平面打打看，这样我们就不用老是换来换去了。好，可以的。现在 orientation is good.
Yeah.
Right.
Yes, I think so.
Maybe 2 clockwise.
I think it's good.
Should be good.
So just because of the aortic hug， 在前叶的下面，它有时候会摆上去的，摆上去那一下我们就发觉，现在上去了下去，压上去的时候下。
哎，这怎么会这样？
对，好。
I don't think so。你 multi view 就是 the resolution will decrease。你还是回到那个 explain 看一下那个，看看那个前叶的。
前叶的下面，你们试试看。
这是前叶了。
对，它摆上去的时候。
我看到这夹子看不到这夹子。
那它摆上去的时候，我们试试看。
再打大一点，现在还能打大吗？
Sometimes it's difficult in this area, even if you're clockwise counterclockwise, it doesn't work because the posterior is holding.
一点点，好，可以。好，它摆上去的时候，
再往前来一点。
Symmetrical grasping.
好，可以。
你的前 arm 前的 posterior arm is not clear。你前臂那个 arm 要给我们显清楚。
我就不能再下了，因为后叶已经抓的张力很高了，也不能再那个。
往前来一点。
好，不能太多了，我觉得差不多就可以翘夹一下试试看。没有。
This kind of case a really challenging case.
Yes,
so
yes.
It's take a time and adjust. So I think
yeah,
not at the same level.
我们还是要把它 withdraw， 然后再调它的 hugging， 再来决定。在心房调
hugging。怎么样？Scenarios you need to clip the P1 or the commissure. How often is that?
顺便把它调清楚。
So what is your comment?
So maybe
at this moment,
maybe you can have a comment that.
Your question? Yeah.
Maybe but
the challenge is
anything we can adjust and any tips and tricks.
In that case, we can control the catheter toward posterior, more posterior. So I mean the more vertical. So in the microclick case, we can use personal, and because in this case, so it is very difficult to grasp anterior leaflet. So.
2的问题。
先把前叶肯定在了。
那你是怎么下去呢？那我们来抓前叶。
先把前叶抓了。
再下去
is not enough.
这是抓了后叶啊。
Before grasping.
你再下一点点。
前叶应该抓好了。
抓住了。
现在后叶在上面。
前叶太多了。
The posterior is above the.
前叶少抓一点。
那就往后叶去一点。
So we will independent grasp anterior leaflet first。
我前叶下了，再往后叶去，我打大一点，看看能不能把后叶兜住。再往下一点。后叶已经，前叶已经张力挺高。
也挺难的。
后叶别动，他在上。
他现在正在那个。我再往后叶去一点点。
要往下一点点。I say we got。
没有。没有，他有时候摆上来的时候
没凑好。
对。
你稍微再往下一点点，稍微再往
下就在前叶。
但是你不能太多了。
对。
然后你要 主要还是 hugging 的问题，还没有完全摆上去。
它上来的时候，你看，
What do you think？
再往后去一点点，
这样抓的就不多了。你还是，
那我们再试一下吧，把这个后叶前叶放掉，我们再试一下能不能一起抓。
我觉得我们把它那个来，我们把全部调出来，再调这个 hugging， 你往前面来，我们全部把它退出来，调一下 hugging， 调着 hugging， 把 hugging 调好。
Can you avoid the anti-hugging?
You know the challenge is the hugging.
Yeah.
If the hugging,
yeah.
所以我们要调 hugging， 在 left atrium，
这都是厚，非常厚了。
We try to decrease the hugging， 你不能完全往后了。
现在好一点了。
啊，
现在稍微好一点。
沿着前臂下。以前我们再看看，再看看 orientation， slow down fast， 看看 orientation， 看看 orientation 啊 ，hugging。orientation 可能不对了。Can you see that?
Orientation.
Too many clockwise.
Yeah. 可以
fine. It's fine.
稍微转一点点还行。
Too many counterclockwise. Orientation 也很重要。
还可以，我觉得。
可以吗？啊，
这边再看一眼二维，
看看二维啊。你看太那个了，太靠那个 commissure 了，要把它往 commissure 外移过来，再往让整个 whole system 出来呢。
往外拉一点，
整个 whole system 出来一点，可能会好一点。
好，往外拉一点点，
往外拉一点，
好，
拉一点。
好。
还不够出来，我觉得来的好像还要看迷点一点。Hugging 还是不是太好。
对，它这个已经调了非常多了。
啊，
好，我们再打开看一下。
看看啊。它这 hugging 还是在。
再打开一点。
两个二嘛要调清楚。靠前，靠前。我稍微给你稍微弯一点。后也可以，前也不行。
对，它这个 hug 很难调过来。你看这个后叶也不行，那已经很多了。
我觉得你这个打的太多了，
哪个？
那个后叶的那个大鞘的弯打的太多，大鞘的弯减少一点，然后再调后叶，再调这个后。
我们可以试试看大鞘多打一点试试看，因为现在就没有其他大鞘，有时候多打一点可能也好一点。
So in this scenario, like maneuvers for ventilation, would it helps in your?
稍微好一点吧。
Maybe, but we don't know it always. Depends on how the movement.
Yeah, you can have a try.
你不要老往 commissure 走，你现在基本上这个甲状往 commissure 了 ，too much commissure， 所以看到看。
哇，现在好一点，现在好一点。
不能太看到 commissure， 现在好像。
现在可能稍微好一点。
commissure 已经，往 commissure 走了。前也不一定夹得住，没什么本质上差别。他要往 leaflet 这边来一点，后叶就是 commissure。
这应该感觉都在了，好像。
一样。
前叶还不行。
I don't see many changes。
orientation 看看。
基本上在这个方向。你看你变成一个 commissure 了已经。完全到 commissure， 所以还是要把它退出来一点，把整个系统再往外一点，可以再弯一点。
方向还行，这边你再看看。
commissure 还行。
好，它后叶上来了，我们再下去看看，或者我们再往前打一点，
兜一点，稍微兜一点，让它跳不出去。
所以它这个就差一点就很难弄。
往前一点啊！
我再往前就后叶就出来了。对，这个病人。
不，你别动，你稍微抓住瞬间的机会。前面还可以，我看两个都上来了，我稍微调一下就行。你看后叶上来了。
好。
所以很
后叶夹住了，
在了，
前叶呢？前叶呢？
你兜起来一点看，前叶它全部扫在这个 commission 里面，前叶这个 arm 看扫清楚啊。
前叶你下了吗？还没下。
我没下。
那前叶你再下看看。
下，你们下，你让它兜起来点，我稍微转一点。看不清，它完全是 commission 了 ，perhaps 这边还是这个没有这个hurdle 没有解决，那再上来一点，稍微上一点，能稍微上一点。
好，上一点。
看不见，不知道怎么样，看不见。
前叶还
这个看不见，看不见。
等一下，我调整一下。
对你把这个看清楚。
它切的出来以后，我们再调一下这个 argin， 差一点点就不行。
But really, this is the real life. We encounter similar problems a lot of time when tackling this kind of challenging anatomy.
Sometimes we will put it deeper, and then we had a chance to catch the leaflet.
现在应该都在了，看看。
是的。
I think both now currently now the both leaflets are inserted.
就现在可能就靠边边了。我真不行，我们就把这个夹了，再 M-TEER 再补一个也行。
So orientation. What is about orientation? Should be okay.
还行吧。
但是 too commercial. Challenges too commercial.
看了看看。
看看。
看了回到2位看一下好了。
So what is your comments? Maybe we close this one to see what is going on, then we make a decision whether the patient need a second one.
Maybe it's too commercial.
Too commercial. I agree with your comments. Too commercial.
The bouncing on the anterior
leaflets. But you know, a little bit tough to grasp.
或者我们先把这个夹了，我们再补一个呢
？Because of hugging problem is hard to be solved. So maybe it's a chance for us to.
You mean you use two clip?
Yeah.
Yes, we have to change strategy.
Yeah, maybe that's another strategy.
等一下，看到这个张力。
So otherwise, maybe we will take too long time.
这边看看张力。
So some cases we really have this scenario that we just put a clip next to that, just isolate the clip and see whether we can just put a very small clip like an anti.
We already closed the commission. I think we sealed the commission now.
好
Let's see what's going on.
看看反流。
So now it becomes two clip strategy. Two commission.
再评估一下。
Could you go back to the 3D and fast or multi-view? Could you guess a multiple view?
好的。
multi-view. 因为一般他们都喜欢用 multi-view. 我们因为老换来换去。
And the
Usually
gradient
this
is
part we assess the gripping and also to see next to it whether there's tissue for grasping.
Yeah.
等一下会不会掉下来了？
没掉。
这个突然压差又大起来了。那你看到压力接差多起来了，可能没抓住又掉下来了。
后叶我觉得会有点损伤。
后叶可能有点掉下来了，掉下来了。所以说把它打开了。
不行了，
我先把这两个起来吧。
会损伤。
对，一下子压差高起来就不对了。
先松还是先起那个？应该先起那个。
对，先起那个。
压差会不会是因为new regurgitation？
对，它因为后叶掉下来了。So because of the leaflet of the posterior.
Still hugging is the challenge. 不是你一定要你往这边切，我们的夹子呢也往 medial 走一点，不要往 too commercial。你现在完全是 commercial 已经，我们连那个 leaflet 都看不见。所以我们
或者我们先把中央的 medial 这一侧先夹。
对，我们要往 medial 走。
那我们先把它，
我们策略是吧？你往 medial 以后才容易这个。比较容易这个，因为现在 hugging 是因为你不往 medial 走，可能反而容易 hugging。
那我们 reverse 先出来。
我们往 medial 走，我再往 medial 走一点，压力又上去了是吧？
我慢慢上来啊。
往 anterior。
好 ，OK 好。
后叶
能往中央来一点点。
Actually, the patient has two mixture mechanism. Not just the prolapse, but also you can see the posterior leaflet has some kind of the tether. So it's a mixture mechanism. Prolapse plus carbon tier 3B.
So usually I have a slightly different way to go in. Usually I close the clip full or make the orientation in the atrium and close it and go in down, put it down. When it open and push it down, then usually they will be changing because of the interaction of the leaflets.
Yeah, I agree.
Can you see that the posterior leaflet is tethered?
We have to go extra deep to that for that, but then the anterior is extra high.
Until now it's too high, so you don't have the possibility to adjust or to wave until the leaflet to be caught.
It's good to put it next to the isolated it and with the first clip inside you, the movement will be limited so that easier to grasp that.
Yes, but now they are difficult to decide where to clip. The first one is more too commercial, so you make a bigger regurgitation from media to that.
整个系统稍微再近点吧，现在或者我们就先到这儿，现在就没有对牢这个。
我们就如果这样，先把 M 次先抓
也不一定好抓，因为那个，因为你还是根本问题还是那个哈根的问题，这样好一点。
再稍微好一点，
好一点。在这里下嘛，我看，在这里下嘛，就对牢那个，不要完全是套在那个里面。那它下去以后呢，又会往，可能这个太大了以后啊，它会往那个。
你看现在是不是脱水的地方，新兵？
现在是脱水的地方，但下去以后会往。
现在脱水的地方对吧？
会往康门穴移。
是的。
那我们这里先夹，等会儿再往 M 侧再夹一个。
M 侧不一定需要夹了，你这里如果夹住的话 ，M 侧不一定需要，因为你夹不住。下去的时候往往你看看 orientation 嘛。
好的。
看看 orientation， 我看看 orientation， 我们打开。你 Multi-View 不能用是吧？
可以用。
你把 Multi-View 打开来啊，已经说了好几遍了。Multi-View 打开来啊。Multi-View 打开来，因为我不习惯看 Multi-View。方向在这里，我看偏这里一点，没关系。
方向应该还可以。
我这里下问题不大，这里下问题不大，我们就在这下吧。
等一下，我 Multi-View 切始。
Multi-View 还可以嘛，我看还可以的。Multi-View 你要在那个上面移，你要在这个水雷电发射上移，把红线对了2个 arm， 所以你就很清晰啊。要不要稍微往后一点点？这差不多。你这个红线移歪了，你红线要正对着这个2个 arm。
Can correct the red line so that blue line so that it is an annulus so that we can.
那个小莲，你那个红线没移准，红线要顺时针、逆时针转一点。红线，水雷电发上的红线，你要 exactly 对着这个，而且你应该
右下角，
哎，你看你斜了。
右下角的，
你背的所有的都是你这里形成的。
右下角，
你不懂，
天平啊，右下角。
哎呀，
对，
右下角是通过这边来转出来这个。
可以的，
或者是通过右下角转出来。因为你 Multi-View 的最好的好处就是右下角转，可以对牢这个夹子的长轴。
移一点，往 median 移一点。对，好，现在对齐了吗？
也不一定，还是哈根。
书记，你们继续努力，我们先进一个演讲啊。
OK，
谢谢。
好，我们等会再回来。
谢谢。
还没有back。
好。
Okay, we have a pre-recorded video from a lecture from Dr. Grube. The new TEER devices are important to ensure.
Good morning, everyone. My name is Eberhard Grube, University of Bonn, and I'm very happy to be at least this way part of Taipei Valve Summit. The topic of my talk is why are new TAVR devices so important to ensure a safe procedure? These are my conflicts of interest, potential conflicts of interest. And I would like to continue showing the TAVR patients in the course of time. 20 years ago, that was the patient group that we were focusing on. That has changed almost dramatically to younger patients and potentially lower risk patients. Consequently, there was a shift of focus. Initially, we planned more procedural success metrics, as you can see on the left side of the screen. And on the right side now, we are doing management metrics, low risk, younger age, more bicuspid patients, and higher physical activity. So the next generation of THV design has to focus on lifetime management and further reduction of complications. We have to set the priorities for the future. We have to optimize the index procedure, very important, extend valve longevity, maintain coronary access, a must in today's world, and a plan for THV and THV. This is an interesting slide because it shows you the trends of aortic valve procedures or replacements in the United States. You can see on the left lower side here, there was an increase in aortic valve hospitalizations from Medicare, both for TAVI and for surgery. The median age decreased in the United States from 84 to 81, and for TAVR and in surgery from 76 to 72. On the right side, you can also see an interesting trend, and you can see here the age group of less than 65 years, comparing TAVR with surgery. In the middle, you see the age group 65 to 80, and then on the right side, you can see the octogenarians, comparing surgery with TAVR. And you can see TAVR is increasing in all age groups, even in the patient group of less than 65, whereas surgery is decreasing. We will see a growth probably predicted, the expected growth until 2030, 300%. So this is a very, very important statement. Alternative materials are being tested, and this research may actually address shortcomings of current bioprosthetic valves. Maybe one time the dream comes true, the promise, open valve for life. We're all working on this, and maybe one day it is going to happen. But there are continued challenges in TAVR today. Bicuspid valves, pacemaker conduction disturbances, durability issues, coronary heart disease in younger patients, coronary access, asymptomatic and moderate aortic stenosis, and of course, geographic imbalances with respect to cost and regulatory processes. So let's start with conduction disturbance and pacemakers. What can we do, and what have we done to decrease the number of pacemakers and conduction disturbances? Well, in today's world, we are dealing with markers, and that helps us for depth control. We know now exactly how deep any valve should be positioned. Here, this is an example of the Evolut FX system, and you can see they added markers in the inflow of this valve. You can see this on X-ray, and you can position the valve exactly where you wanted to have it. This is being supported by an optimized stability layer, single shaft spine, and in general, for all valves, enhanced visualization. And that is true for all THV devices. Next complication, bleeding complications. So we have to look for alternative access. This is a summary, even though this is not so important in today's world because most of the procedures can be done transfemorally, but nevertheless, if transfemoral is not an option, then we have to look for alternative access. And in order to do that, we have to decrease the delivery catheters. Important here, I can introduce the Valve Medical ZMED THV. It's a modular system. And you can see here on the left side, the valve module. On the right side, you can see the frame, and in the middle, the assembled device. In addition, you have a two-component hydrogel addressing PVL. This material swells once in contact with blood. And then you have the 3D piece bovine, hopefully conveying into better durability. So here is a summary. This is an ultra-low profile, true 12 French TAVR system. And the 9 French equivalent inline sheath system comes in the fourth quarter of 2024. And in the lower part, you can see the ZMET in green, comparing it to Evolut and Actuate Sapien delivery catheters. So that might be a way to reduce further bleeding complications. And then, of course, the question of bioprosthetic durability. It's all about leaflets and material science innovation. Three examples: the Antares Duravat THV from Antares, the Edwards Resilia tissue valve, and the Foldex valve with polymer leaflets and robotic manufacturing. Here you can see the Antares Durav THV. It is a very new technology with a design goal to restore near normal hemodynamic function, better coaptation and less leaflet stress and better durability, hopefully conveying this concept into longer life and better durability. This is a very interesting concept, and it is moving very rapidly forward with excellent clinical results, as shown here. Very, very good opening areas as compared to conventional valves. And, you know, it is almost normal opening area if you look at the right lower part, and very, very good hemodynamics. So we will see how this valve is coming along. Although I have to say, we have to be careful. This 3D one piece is really improving durability. At the end of the day, only time will tell. Be reminded that the MitraFlow valve, which we all know doesn't have such a long success story, also had a single piece of bovine pericardium. So that single piece bovine pericardium did not translate into better durability. We have to be careful. The next one is aortic regurgitation. We know that has to be addressed, because bicuspid aortic stenosis will increase with younger ages and consequently also aortic regurgitation. We know with conventional THVs, we do not have the best valves for this patient group. In almost 30%, we had to use more than one valve, as compared to 4.1 in the aortic stenosis cohort. We have to secure the first valve with the second valve. And then also, we are left with moderate aortic stenosis in a considerable percentage, 15.3%, after implant of conventional THV. We're still dealing with moderate aortic regurgitation. So there are limitations of TAVR in this particular anatomy. So we do need dedicated TAVR devices to address symptomatic aortic regurgitation. And we do have those valves. On the right side, the Jian'an trilogy valve, and on the left side, the JC Medical J valve. These two valves are addressing specifically aortic regurgitation with great success. As here, as an example, the ALIGN study with the Jian'an valve, we have excellent hemodynamic valve performance, basically elimination of paravalvular regurgitation, and very nicely shown left ventricular remodeling, so the left ventricle gets smaller, and the functional class of the patients is increasing. The patients simply feel better. And then, of course, lifetime management, valve-in-valve procedures. And this is an interesting valve-in-valve market forecast until 2035. And you can see in gray, the numbers are exponentially increasing, and in blue, the TAV and TAV procedures. So we will see in the future 6 times, probably more than 6 times more increase in valve-in-valve procedures. We have to be prepared for valve-in-valve procedures, as I stated initially. So we have to plan for future interventions when we deal with younger patients. How do we start? Which devices do we start with? The goal is to minimize open heart procedures and avoid performing them when patient is older and at higher risk. This is a very nice summary by Dr. Tarantini, and you can see here lifetime management of aortic disease. If the first intervention is surgery, what should be the second intervention? Should it be surgery, or should it be TAVR? And you can see here, looking at the mortality data, clearly the second procedure is definitely in favor of surgery, of TAVR, as shown here with a lower mortality. Here, if the first intervention is TAVR, what is the second intervention that we're looking at? Surgical explant, shown here with a fairly high mortality. Explanting those valves is not all that easy. Or is it also TAVR and TAVR? Clearly looking at mortality in favor of TAVR, both. If first intervention is surgery or TAVR, the second intervention should be TAVR. So the first cut is definitely the deepest. TAVR will likely be the most frequent second intervention in a lifetime management, and TAVR repeatability might be as important as leaflet durability. Regardless, the second intervention has to still allow coronary access. Anatomic and device features have to allow the access to the coronaries, because in the lifetime, the patient may actually develop coronary heart disease. And lastly, and importantly, why are these new TAVR devices so important? Well, it is simply a market issue. And we know there are geographic imbalances regarding cost of those valves, extreme to very low, and there are regulatory differences in the various countries. Different valves stimulate the marking and eventually will lower the price. It is very, very important that we keep doing this in the future. So, caveats to consider if we look at TAVR newcomers. There is no single perfect TAVR system. Strong subjective opinions regarding features. There's significant operator experience necessary to formulate thoughtful impressions. And future TAVR systems should be expected to treat all patients with aortic stenosis. What is hot, what is important with TAVR newcomers and new technologies? Meaningful new versions of SAPIEN and Evolut. The industry leaders continue to iterate and innovate. Rapid emergence of other TAVR systems, for example, Actuate Neo2 or Prime and the Navitor valve. New TAVR systems from China and India are entering the clinical marketplace. Venus, J-Valve, MyValve as an example. And TAVR newcomers are developing novel device system, dry leaflet technology, PVL prevention, and ultra-low profiles. Tissue engineering concepts are quickly evolving and may spark a future round of improved valve leaflet designs. New techniques for lifetime management and AV remodeling are increasingly being used. With that, I would like to finish and thank you for your kind attention.
So I think Professor Gubier, this talk summarized everything. So we still need to work on, although we have very good results now with good devices, but we still a long way to go to achieve perfection, especially for managing our patients.
We are eager to see the new device, maybe knife French. 100% transfemoral.
So I think it's also good that we can have our ideas, that we can feed back to the industry, and actually we are the user, we know what actually is deficient. And
however, the knife French, I think, is a big problem because the tissue is thinner and the durability.
I just want to comment on that because durability is always an issue, because you put maybe a device or a new valve in a younger patient with longer life expectancy, and that may raise the issue of durability. Maybe we continue the next session because the live is a little bit get stopped, and maybe we alternatively to do the program. Okay.
Yeah. So that's let me show that introduce the next section is a workshop. That's this year we try to hold a new workshop for CT analysis in Bapat procedure. I think it is very important because people just know how to do that. However, do not know how to use your image system or how to measure the VTC or the VTSTJ and what is the risk. So I still learn from this field, and I think that Simon have a very good experience about how to do the VTC, VTSTJ, and the risk of the TAVR implant, especially for the TAVR in the future. It's easily growing very, very rapidly for the risk. We should know more about the risk of the risk plan or any other things. And let's we start the next section. The first case is Dr. Liu. So we wait a moment that they have a shift for another section. And I hope you enjoy this section because the next year we hope we have a full-time workshop for the CT management. And in my team, we develop a program for young implanter and the surgeon, and more information come in, and we hope that the experienced implanter here can teach us to and share their experience, and we will showcase, and we have CT image here, and if you have an idea, we just measure that and see what's happened. Okay. This first reporter is Chia-Ju. He's our new implanter, and he also is a cardiac surgeon. Now he get a very experience in joining the team, and he also do a lot of surgery. Then we welcome Dr. Tsai.
I'm Chia-Ju from Jian'an General Hospital. And this is a 72-year-old man who had received TAVR with the 29mm core-valve implantation in 2070. And the cardiac found severe prosthetic LT valve regurgitation and severe valve leakage, and suspect IE related. redo operation was suggested, and the mortality risk about 35%. And this is his first TAVI MSCT. It is a type 1 bicuspid LT valve with the RL fusion. And there is a big classification at the LN commercial. And the annulus diameter was about 33, but the waist method was about 24.5 millimeter. The sinus vasa and the coronary height is big enough, and it was low risk of the coronary artery obstruction. So we used the 23 balloon for predilatation and deployed the 29 millimeter core valve and the post-dilate with the 26 balloon. And the final result showed the mild to moderate valvular leakage at the calcification raphe. Then we follow the cardiac echo. There was the cardiac echo from 2070 to 2024. The valve function was well, and the valvular leakage was almost the same. But in March 2024, the echo found about 1.6 centimeter vegetation at the positive valve leaflet, caused the perforation of the positive leaflet, result in the supraannulus severe valvular leakage. And this is another view of the previous valvular leakage at the classification raphe from the transgastric view.
So that we stop here, and we got enough information about clinical background. So this is a best selection case. Younger patient received the TAVI and have the residual valvular leakage. Now, 6 years or 7 years later, he become endocarditis. However, this patient did not have any other symptom about fever or any other bacteremia during the past 6 months. And this is because of a short patient visit clinic and found there is a vegetation-like material in his echocardiography. So he refused to do surgery. So there's a plan to do a transcatheter surgery. Do we check the CAT scan? Dr. Liu, please show the CAT scan. So let's we measure the previous the CT scan.帮刘医师找个椅子坐。Okay, this is the 3-main cell, and we measure the CT scan. Do you check the valve implant in the depth 6 or 3? I think that the distance to run the depth for the first implantation, it should be 3 or 4. And this is the CAT scan over here. And could you show the leakage over here? So it's compared to the echocardiography, leakage should be just around the raphe because the core is not fully expanded. Could you measure the inner diameter of the waist area, the constraint area over here, this picture?再往上。Okay, here, the inner diameter. No more about more the waist region. Right. Yeah. It's 20. It's a big problem because 29 at this stable should be at least 23. So there's under expansion of the co-op. So Professor Ye, do we need more information about this case scan if we need to do the Redo-TAVR in this case?
So I guess this is the first question is this the endocarditis or not endocarditis? I think that's a very important question. And because that will change your management, right? So the AI, how long has this patient had AI? Is it very pretty new, or is already for like 6 months or the?
Nobody knows because the patient say that during past 6 months he do not have any symptom about fever, cough, or any other where. Because of short breath, he visited the clinic.
So from the only my concerns is as this is the old core valve, right? It's a porcine, right? Initial is a porcine.
Yeah.
So I think for the flare leaflets, the porcine usually can cause a flare. So that's not necessarily to the endocarditis. But the only thing the perivalve leak is increased significant. That's a little unusual because for so many years later, you should increase the worsening perivalve leak. So have some underlying issue. So on the CT, because it's so calcified, so it's a little difficult to say there's any small abscess or not. Is this a contrasted or not contrasted?
It's contrast.
Okay. So I think that sometimes you have to consider is culture negative endocarditis because that can be actually is not that infrequent, even in the surgical valve situation. So it can be like for several months is actually culture negative. So my question is if this cannot be completely ruled out, I think this patient, if you consider for TAVR, first you should consider for antibiotic treat for culture negative ID for several weeks, I would say before to consider valve if you can not rule out completely.
Actually, the patient received the 6-week antibiotic.
That's great.
And every 3 days we check the blood culture for 2 weeks, and then every week we have blood culture. No evidence of endocarditis. Every specimen is negative, even we culture for 2 weeks.
No, that's good. That's good. That's great. So that's my. So whether you need to treat it first, I think you need to treat it first before you do intervention. So I think another thing is, yes, this is clearly. I think initial is it's asymmetric bicuspid valve, really asymmetric bicuspid valve. So one side is extremely calcium, one side is not really calcium. That's why the valve is so shifted. So in terms of to expanding this one, I would say I'm a little bit conservative to expand more. Of course, you can expand it to some degree, but I will not expand it too much because you see this valve is so shift to the one side rather than because this calcification, I don't think you can break on this side, the calcified side. So expansion will more towards the non-calcified. So I think for the perivalve leak, you can expand it to some degree, maybe eliminate the perivalve leak. But whether you can completely eliminate the perivalve leak, I think it's doubt. I would doubt it, but I would say you probably can reduce to some degree and with some expansion. I think that's reasonable if patient is too high risk for the surgery. That's my opinion.
Okay. How about consider lithotripsy? Do you have any experience on that? Yeah, I mean lithotripsy.
intravalvular lysotracing.
Do you have any experience at St. Paul?
No, we haven't done yet for the valve.
Okay.
Sorry.
So Eka, do you have an idea about?
Yeah, so I think this is obviously very hostile anatomy. I mean, even the first procedure already. I suppose you selected a self-expanding valve because so heavily calcified, worried about annular injury. Yeah. So I think in this case, I mean, if you have excluded the endocarditis, yeah. Then in this particular case, you have the coronaries are very high, so you don't have an issue with coronary access in this particular case. But I think you're still going to deal with the risk of annular injury if you use a self-expanding valve, because you will expand this core valve as well. Because if you go with, so the question is the sizing of the sapien valve that you might consider here. Because do you size it based on the old CT or based on this new CT?
So there's a from the paper given is not here. So the first thing I will ask every expert is node 1, node 2, node 3, node 5. For this case, is important or not? And in this case, it's an important issue of the leaflet overhang. Is very important or not? And I think that most people ask implant to put the sapien valve in node 5. And maybe we can show there's a node 5. Where is node 5, and check the area, please.
Actually, personally, I don't care about the node. Yeah, because we respect the original anatomy of the artery root. So, as I mentioned yesterday, the first day on Friday, in our center, we care about the location of the coronary takeoff. If we can put the new valve just below the takeoff of the coronary, I think even we have some leaflet overhang, I still can accept that, because hemodynamically in the long run we don't know. But recently there has been no data saying that the leaflet overhang will compromise significantly to the hemodynamics. So if we want to put the second valve, I will just aim at the low margin of the coronary takeoff. I think that would be better for the future coronary axis.
Yeah, give it here, and maybe that he can give us a section. This is a case of bicausal valve. He received 29 core valve and had residual moderate pleural leakage. Now, the limited possible inpatient endocarditis, however, is treated, refused to do the surgery. So that this is a multi-stage CT here, and initially we got confused about where is the implantation frame, and if the bigger issue about the leaflet overhang in this case. So there's we have the CT over here, and we have the doctors do the CT over here. They can show you if you need more information.
Hi, 你好, 你好. Hi, hey, Professor Wang, how? 你好. Hey. Hi, Gilbert here. So I think the first question is, what is the implant depth of this core valve? So I think we need to go to the annular plane to scroll down to see. Looks like it's good, because that will determine where your neoskirt plane is going to be. And you said the mechanism is PVL. Mostly. So with PVL, you will, and a flare leaflet. So the good thing about that is that you do not actually want to implant too high, because then you will not seal properly with the paravalvular leak. So we usually then calculate, you can use the Bapat's app to calculate the inflow dimensions here, and then you just go systematically by node. So you go node 1, node 2, node 3, node 4, up to 5 and 6. And then you average the number of your landing zone of your sapien 3. So in this case, you're more likely going to implant between inflow to about node 4. So you do not want to go below 0.4 because you can rush the risk of embolization. So we would measure the in vivo sizing like you see here, and based on the average, you would pick the right valve. So in this case with PVL, and we would have to do the measurement now to determine, you probably will do 26 sapien 3, maybe take some volume out to avoid any annular injury, because you can see above where the calcium is, it's very dense. So you can run the risk of root injury as well. So that would be probably my approach without doing the complete analysis.
How about the paraleakage? Do we need to do the paraleakage or just implant the sapien?
No, that is what I mean. So it's very hard to do the plugging here because it's a tall valve and you need to see where the paravalve leakage is. So you will never completely remove the paravalve leak, but you can maybe go from moderate or moderate severe to maybe mild at most if you are lucky. The key here is to help circularize the core valve frame to help reduce the leak around the area. So, but this is very, very hostile. You can see that that calcium there, that's where the leak is, because you can see it's not sealing anywhere around. I mean, after that, you can still maybe consider do a percutaneous closure if you think it's feasible.
Yeah, so that's a parameter area is around 20.2 or 20.5. So that's is make us to confuse if could we expand a little bit and decrease the paravalve leakage.
Yes, that is the idea, to expand the core valve frame with the sapien, because it's more radial force, to reduce the paravalve leak, and also to treat the flail leaflet, like you said, with aortic regurgitation, the transvalvular aortic regurgitation.
So your suggestion is 23 valve with a -1?
No, 26 minus, because 23, I worry that it will not seal properly.
Yeah.
You will have to, I mean, we have to measure to see right here what the...
Current internal diameter only 20.
Oh, only 20. Oh.
Do you show the waist of this valve? Sorry.
What's the measurement of 20?
刚刚你那个 waist 那个地方。
这个 virtual valve 是那个 size 啊
26.
Oh, 323. Oh, wow.
It's always happen because we hope to choose larger valve. However, in the upper part is a narrow cis1.
So yeah, so I think if you go to I think you would have to do a 23. Yeah. But I would pre-dilate this first to expand the core valve frame a little bit more before you put the 23. So that's 26 and 23.
Yeah.
Gilbert,
but my concern is still the 23. If you go to the inflow, there's still going to be a leak. If you keep going down now, look, it's like not really sealing because LVOT is so big now. So I don't see how you can fix this actually.
I'm sorry that we must stop here because
no. We discuss this case, then we ask Professor Wang to deliver the talk. I just wanna.
What does Professor Wang think? Let's ask Professor Wang what he thinks. So.
Hi, Professor Yin and
yeah,
yeah. Good morning.
Professor Wang, do you have any comment on this patient?
Sorry, I didn't. I didn't spend enough time on the case just now presented, so I cannot give.
Okay.
I don't have comments
then
on it.
maybe we have Professor Wang to deliver the talk regarding the M-TEER in China first. Thank you very much.
I thank you, Professor Yin, and thank you for inviting me to join the important meeting, and also congratulations to very successful Taipei Valve 2024. So I just left the left demo the surgery room. That case is a very challenging case, which is still going on. So switch from there to the presentation room. So I would like to share with you my presentation. So can you see my screen? Professor Yin?
Yes, we can see that. We can see that.
Okay.
Please, full screen and start your talk.
So now is on the full screen model. Can you see? Is it now?
Yes,
on
please.
The full screen. Okay. The title of my presentation is Dragonfly for mitral transcatheter edge-to-edge repair in China. So my name is Jian'an from Second Affiliated Hospital, Zhejiang University School of Medicine. So here's my disclosure. So the Dragonfly has been widely applied in more than 150 centers in China. So more than 2,000 TEER procedures have been done in China. So I would like to introduce you the structure of the Dragonfly. As you know, Dragonfly consists of three main parts. So the guiding sheath and steerable sheath and CDS. So each of sheaths has two knobs. So one for controlling lateral and medial, the other for controlling anterior and posterior. So both of the knobs are articulated. So also the Dragonfly has other features like the central compressor filler and adjustable closing angle arms. So precise control system, including readable indicators and rotary knobs. So it has independent grasping function. Also has real-time left atrial pressure monitoring, and it has 4 clip sizes. Also, it's good for both mitral regurgitation and tricuspid regurgitation. In terms of Dragonfly milestone, so the first animal study first animal study kicked off in 2019. So first patient was successfully performed in July 2020. So in 2022, we did a live demo in the TCT successfully. And so 1 year outcome of DMR released in PCR 2023. Also last year we shared our experience of Dragonfly in CSI. So the device was approved by Chinese government in November last year for the DMR. So here's about the pilot study. In pilot study, we enrolled 23 patients, including 12 patients with a degenerative DMRI and the other 10 with a functional MRI. So from 3 medical centers. So the average age of patients for the pilot study is about 76. So 78% of patients with mitral regurgitation 4+ or larger. So you can see that here's the etiology for enrolled patients and also the regurgitation position for enrolled patients. So outcomes of the PEER study is, you can see that at the baseline, so most of patients has severe mitral regurgitation, but the post-procedure, after post-procedure, we can say that no patients with moderate or above regurgitation. So 1 month after procedure, still, you know, the outcome is very good. It's still good. So after the PEER study, we kicked off the pivotal study. So for pivotal study, we have 2 arms. You know, all of patient we have 2 arms, one for DMR, the other for FMR. So all of patients enrolled with moderate to severe mitral regurgitation, the 3+ or larger than 3+. So 120 patients enrolled for DMR, the other 120 for FMR. So the DMR patient, the 1-year outcome has been released. So the device is also approved by the Chinese government for DMR. The outcome of FMRI arm is still pending. We're still waiting for the result. So, so in terms of the enrollment and the baseline characteristics of the DMR study, so we can say the 120 patients totally was enrolled. 117 finished the 30-day follow-up. 113 patients finished the 6 months follow-up, and the 1-year follow-up, there are 112 patients finished the follow-up. So we can see the average age is around 75. The male gender is close to 50%. We can say that the price stroke rate is 13%. So STS score is almost 7. The NIH functional class 3 to 4 are dominant. So KCCQ life course score is almost 45. The mean left ventricular ejection fraction is around 60. So the average number of clip is 1.5. So you can see here's the size distribution, number of sites. So the implantation location, we can say that's 17 for the A1P1 and 129 for A2P2 and 35 clips for the A3P3. So you can see that here's the number of clips successfully implanted. Regarding the primary efficacy composite endpoints at 1 year, so we can see the freedom from all-cause mortality, surgery for valve dysfunction, and over moderate mitral regurgitation at 12 months, free from the freedom rate is almost 90% at 1 year. So major adverse events, so adjudicated by CEC, so we can say that. So deaths at 12 months, 5%, cardiac deaths, 4.2%. So non-cardiac deaths, 0.8%, stroke rate is disable stroke rate is 2.6%. So renal failure is 2.5%, and cardiovascular surgery 2.6%. So the MACE safety endpoint, we can see that is 12 month, 9.2%. So all-cause deaths, 5%. So cardiac death already introduced you. Regarding the mitral regurgitation and NYHA functional class, so we can say from baseline through the 12 months. So even at 1 year, most of patients achieve great reduction in mitral regurgitation. So you can say that. So the 93, almost 94 of patients keep the NYHA functional class 1 or 2 at 1 year post the procedure. So about the QCCQ score, you can say which was significant improvement at 1 year. So according to the left ventricular reverse remodeling, so you can see, so after the procedure, left ventricular volume and left ventricular diameter at 1 year. So also we, several months ago, we kicked off the Europe trial. So I'm one of the 4 PIs. So we are going to start. We start from the DMR case. So totally we are going to we start from the DMR cohort, but we are going to do both the DMR and the FMR cases. So on the design, we are going to do 40 cases for DMR cohort in Europe and 45 cases for MR cohort in Europe with a Dragonfly. So also we, almost 3 years ago, I did the first case in China mainland for the transfemoral TEER by transfemoral TEER to treat the TR using the Dragonfly. So until now, we have done more than 50 cases. So here's the summarization of 47 cases. So the age is, the average age around 70, the female is dominant. So the NYH class 3 to 4 is almost 70%. So we can say that regarding the TR grade, 3 plus 30% is about 30%, 4 plus 45, and 5 plus torrential is about 25%. So pure functional TR is, is almost 90%. So the average procedure successful rate is around 95. Device time is 123 minutes. The average clip number is 1.86. So the device implanted, device implanted, 1 clip for 21 patients, 21% of patients, 2 clips for almost 70% of patients, 3 clips for almost 9% of patients. So procedure-related mortality is 0. So we can say that regarding the grade reduction at the 30 days for 41 patients. So we can say 5% of patients has no change of the TR severity, but 34 for reduction more than equal to or more than 3 grade, 24 of patients for 1 grade reduction, and 37 of patients for 2 grade reduction. So even you can say that even at the 6 months for 27 patients, you can say that still have a significant reduction in TR severity. So here's my conclusion. China is in a stage of rapid development of TEER. So many MR patients are looking for the treatment. So domestic TEER devices are booming. So pioneered by Dragonfly. So Dragonfly will be the first domestic transfemoral TEER product launched in. Dragonfly is the first domestic transfemoral TEER production launched in China. So Dragonfly is suitable for patients with MR of a variety of lesion types, which is in its pilot study and DMRI studies verify the efficacy and the safety of the device. So we are looking forward to building a real-world clinical data with Dragonfly and reaching more patients worldwide. Thank you for your attention. Thank you for your time.
Thank you, Professor Wang. Yeah, I noticed that there is also a spacer, something like the Pascal design. So what's the difference, and are there any difference, really difference? Thank you.
According to the spacer, I think it's, regarding the spacer, I think the design is totally different between the Dragonfly and the Pivotal, or under the Pascal, You know, the Dragonfly actually it's not a true meaning of the spacer. It's we call it a filler. So it could be totally compressible. So made like the without the spacer, but also can keep some the angle. I think up to the 45 degree. Keep the two-arm angle up to the 45 degree. So from 0 to 45 degree, you can let the two arms stay there even after releasing the clip. Now, also, I think the manipulation, you know, the part is quite different from the Pascal as well. But you know, Pascal has not been accessible in China until now.
Okay. Thank you. Any other comment? Gilbert, you want to comment?
Yeah, Professor Wang, thank you very much for the presentation. Very exciting device. Unfortunately, will not be coming to the United States anytime soon. But congratulations on the European trial. I think that's going to be very important in terms of this technology being compared to other existing technology in Europe. And of course, you now have MitraClip G4 as well in China. So how do you decide which device to use? MitraClip versus Dragonfly, for example.
I think especially for the beginner of the TEER technique, I think very important too. I think the Dragonfly looks more easier for the beginner to learn how to do the TEER procedures. The Dragonfly G4 is the MitraClip G4 is quite good. So, however, it's still it was improved on the old platform, actually, which was developed 20 years ago. So the currently, I don't think its manipulation is so, it's a little bit tough especially for the beginner. When we meet some patients with a small left atrium, but when you use the Dragonfly, it's very easy to finish the procedure. Even before your achievement of the straddle, you can bend the steerable sheath, but for the MitraClip, it's very tough it's obviously impossible to do the bending before you achieve the straddle. So it's very good for beginner.
Okay, thank you. I would like to thank you for your support of this meeting, and especially making you rush from New York to Zhejiang. So thank you very much. We appreciate for your support.
Thank you all.
Yeah. Thank you. Then let's continue our program. Yeah. Dr. Lee.
So Gilbert, I think that if could we implant higher, even the node 5 or node 6, and how do we measure is it safe or is too dangerous to do that?
Yeah, I think the problem if you implant high, you are not necessarily sealing against that chunk of calcium on the bicuspid. I think that's what you are sealing. If it's stenosis, then implanting high will be okay. That's my concern, that you have a very dilated left ventricle already. I think if you look at the TEE, you can see there's probably a gap between the frame and the left ventricle. So you have to evaluate on echo where is the paravalvular leak happening, and whether expanding this frame further will benefit from the perivalvular leak. I'm not 100% convinced that it will be. And to your point about the sizing, yeah, I think based on this anatomy, you are almost committed to a 23 millimeter sapien. You know, the inflow is larger than is 454. So I would implant probably around no 5 probably. Because remember, 23 valves is a shorter valve than a 26, and it's not going to foreshorten completely. And so you try to expand a bit more to seal against the bicuspid calcium, and then you would have to post-dilate to try to expand further and then see how the PVL will look.
So the data type, could you show us how do we do?
And then we tried to use the occluder for the perivalvular leakage at the classification Raphael and use the sapien 3, 23 millimeters. And this is what we do during the operation. So we cannulate to the perivalvular leakage and put the occluder at this side and the sapien 3 at here. Then we deploy the occluder and check the left main position. And we open the sapien to find open sapien 3, and the post-operative there is no perivalvular leakage at the echo or Rchocardiography. And the result there is almost our AR index was about 46, and the LT valve pressure gradient was 3 millimeter mercy. So the device was succeed, and our occluder at the classification Raphael, and the position was about 3 minutes per placement of the previous annulus, and 3 minutes light above the inflow. And there was no residual perivalvular leakage.
So I think that should be at the no 5.
Yeah, no, this is very good. So the key strategy here, so in this case, is that you do a dual strategy. You need to plug and then put the second valve to increase the radial force against the plug to reduce the sealing against the area of the landing zone. So yeah, I think no 5, and the root is huge, so I'm not worried about coronary obstruction at all. So I think this is a good position in terms of the, and you did a nice, very slow inflation to control the depth. So.
Yeah, I have a question for you, because we did not pre-dilation this because the Leaflet is flare. Do you think do we need a flare, and maybe we can implant 23 more plus 1 or more?
I would actually, I think with the 23 nominal, it probably would seal already, because it was a 20 on the measurement, so 23 already feels like it's oversized. So I thought I would have actually -1 and then see how it goes before adding, because I'm always worried about annular injury, but this looks great.
Thank you. Maybe if any audience has the question, or Jimmy, please.
Your Redo-TAVR was 3, wasn't it? And that's pretty surprising, because if you had put a sapien valve in this particular case, and you do an echo, you would not expect a mean gradient of 3. But now you do a TAVI in TAVI, and you get a mean gradient 3. Maybe I'll ask one of the clever cardiologists, how do you explain this through the echo physics side of things?
Could you show echo after the procedure? Yeah. No, it's okay. I think that this picture did not show any areas in the middle, so that's In our idea that the bicuspid aortic valve, even the valve is small. However, we put the valve open quite well, and the pressure gradient can remain high, in relatively low. So how about Professor Ye have the idea about this?
I just want one comment. So this valve is under-expanded initially. So if it's fully expanded, I totally agree. You need to put a low or high. But for this valve, actually, you can put a high, no problem, because it's under-expanded. So when you expand it, this stent will form complete seal. So for this valve, I will agree. I will before you show this size, so that I will put a little high rather than lower, because it will be sealed, because it's so under-expanded. So I think that's great result. In terms of gradient, because this valve was so under-expanded, so the valve was really small, it's only 20. So you put a 23, it's now become bigger than initial valve. So gradient is very low. That's expected. So I think it's an excellent result for this. The only thing is that you did a full balloon initially, or you reduce 1 cc or 2 cc?
No. Just a full.
Pretty brave. I would say from 20 to 23 for this route. If I do, I will be a little conservative. Probably will reduce a little, and then I started to probably improve. But excellent result anyway.
Yeah, it's too brave. I believe it. And because a lot of times we do the bicuspid aortic valve, use a larger valve. The stent cannot resist the recoil force. So this is why we try to use a nominal volume in this case. And it's why sometimes if the calcium is too severe, we just use the septic valve, because the stent always the constraint in the middle.
One question, for the internal occluder, you put the occluder before the valve implanted. What any comments you put it after or you before?
I think we've seen a couple other cases. It's easier to put it before, and then you basically afterward, if you smaller gap, it's harder to cross. You have two valves now. So I think if you can deploy it's not going to embolize, it's not going to fly away. So now you got some plug, and then you just expand more to seal that. You just have to hopefully no hemolysis afterwards.
Yeah, that Professor Yin makes the decision for the plug. Maybe he can explain more about the plug.
Yeah, usually we put the plug first. Yeah, makes things much easier. Because the other thing is that after the second valve, you will compress further. So that makes it maybe the track of the paralytics smaller, and makes plugging much difficult.
But there's a possibility you don't need a plug after you're 23.
I don't think so, because the space is still there. You dare not to make it that big.
It's an extra sealing skirt with the plug.
Yes.
So let we move to the next.
Do you give antibiotics after this case?
Yes, continue for another 4 months.
Okay.
4 weeks. 4 weeks. Yes, before have 6 weeks and after 4 weeks. Yeah.
I'm Dr. Hong from Zhenxin General Hospital as well. So this is the case I want to share. TAV in SAB. The 84-year-old male has a problem with the aortic stenosis after possible prosthetic valve endocarditis. He had aortic valve replacement and CABG in 2014. And actually, from the previous cardiac report, there was no abnormalities like the valvular dysfunction or valvular stenosis. But in the recent cardiac report, in the early April, he had from that report, we can see there was a aortic valve narrowing. So considering his age and also his health issues, at that time we referred him to the heart team for further evaluation. So as you can see, his hematocrit is 22.1%. It's pretty low just because he had the myelodysplasia syndrome and he had the high creatine level. And also his CAT score is 3 out of 6. It means he indicates some assistance from the daily task, and also his STS score is around 43% the risk of the mortality. So it means this patient is classified as high risk of the reduced surgery. So, and another thing I want to mention is this patient, during the pre-TAVI checkup, we found VRE in his blood culture. So we delayed his TAVI procedure until the reset of the blood culture negative, and that's it. So here is his echocardiography before the TAVI. We can see that a thickened bioprosthetic aortic valve with a preserved cardiac function. And also we can see the minimal valvular aortic regurgitation, but no paravalvular leakage. His pressure gradient is pretty high, around 54 over 90 millimeter mercury, and the aortic valve area is pretty small, 0.66 square centimeters. So we
Please stop here, Dr. Liu. Yeah. Do we have a screen over here? Yeah. So this is our measurement. Beside the app, we always check the annual size. And do we show the annual size over here? Remove the processes. Okay. The first question is always just like this. And how do we measure the correct size? Is just check the meta-ring, or just check in the middle, or just the inflow area?
Yeah, I mean, you measure what you can see here, what you just did, but the reality is the true internal diameter is a little smaller because of pannus, because of other materials. So, but you go by what you see here, which makes sense. The 23 epics of porcine valve, right? So if you look at Vinny Bapat's app, it will be, the ID will be around 20, 21, it will be small. So likely the valve of choice will be a 23 evolute, most likely. In this case, looks like it'll be a 26, which you can do. The epic is fracturable, so you can consider fracture, and it looks like the root is big, so you can consider fracturing in this and put a 26 evolute in there.
But you check the VTC?
Yeah, I mean, usually I don't check the VTC if the top of the surgical valve is below the coronary wrist plane, because it's like Redo-TAVR, it's not gonna matter. So it's sometimes it's so far away that I don't even measure, because there's no way that it's gonna be, occluded. So, yeah, so it's very benign, yeah. Exactly. And also remember, like mitral valve in valve or aortic valve, the porcine valve, the leaflets don't go all the way to the top of the commissure. It's actually a little shorter. So it's even more generous. But of course, for conservative estimate, you would go at the level of the commissure. So you can see, if you rotate here, it's below the coronary wrist plane. So I don't really care about the.
So the problem is pannus formation will affect on when we put in a valve.
Epic is hard to see because the sewing ring at the base is very hard to visualize. So sometimes you might have to do an aortic angiography to see where the landing zone is. But this one is, with the high gradient, I may pre-dilate a little bit just so you can cross easily, because sometimes I find this big aortic root, especially horizontal, it's very hard to cross with the evolute platform. The self-expanding platform, it can buckle and bend into before you cross into the annulus.
Yeah, that's Eka. Do you think it's enough, or you need more information?
So this patient's, when was the EPIC implanted again? It's 2014, is it? Or?
14.
10 years ago.
Yeah, because I mean, some of this imaging of the hypoattenuation of leaflets, I don't know if it was earlier, it could be some degree of thrombus. So, but I guess it's anticoagulated because it's atrial fit patient as well. So most likely Panus, and I agree. I think it looks quite a spacious route. So if you want to get better hemodynamics, I mean, a fracture with a larger valve seems possible.
So that you give us a very important issue is. If this is a thrombus, and do we need the anticoagulant maybe for 6 months or
that? Just based on CT, I don't think it's above the annulus. That's the ingro. That's not the ingro tissue, because you can tell this is not the ingro tissue. It's on the leaflets or the struts. So the bottom part is you probably is ingro, but above that, I don't think it's ingro tissue. So the question now is the thrombosis or the infection tissue. That's the main question here. And another question for endocarditis, how long you need to wait after the antibiotic before you implant another valve? So that's a questionable. And I just wonder how many culture you done after the end of the
should be around 6 or 7. And initially
6 or 7 days?
No, there's initially he admitted to hospital. He had 2 culture for enterococcus. And after 2 weeks of treatment, the culture negative. And then another 2 weeks for the treatment.
Okay. That's another question, how long you wait? So I intend to wait longer. I intended to, unless patients are really unstable, because in the surgical situation, sometimes they do have a recurrent endocarditis. You have to stop antibiotic for months so they can recurrent, because these kind of falling material that you really cannot kill all the bacteria in the sewing cuff area, particularly this kind of lots of sewing cuff for the pig valve. So I usually intended to wait for several months after the antibiotic, and then a culture, and then do echo. If no recurrence, I put it there, and then antibiotic for a long time, almost whole life. So that's kind of the things, the possibility. So I think this tissue is a little wallet to me. It's very bulky tissues on the leaflets, rather than the annulus, like a sewing cuff. So this as whether it's thrombosis. It's tough to say because it's so late. Usually not thrombosis, right? So I think whether this is an infected tissue or not, and that's my real question.
Fortunately, that after surgery, he has maybe at least 3 or 4 cultures is still negative. We still keep antibiotic, and he discharged with antibiotic. For maybe we keep on the antibiotic and watch CRP and any infectious marker. Maybe he need a lifelong antibiotic, and he's 44, 84, so that we won't do any other things to this patient.
Enterococcus is a little better, but for Staph species probably will be more worry.
So that's a. Please go ahead the next slide. Next, yeah.
Should I directly jump to our strategy, or should I continue our MSCT? Because we can see our MSCT at phase 30% of the cardiac cycle. We can see that patient have the hypoattenuated leaflet thickening. And when we measured the level at the aortic annulus, sewing ring, and the LVOT, we can find no significant differences among them. And the sewing ring height is 5.5 millimeter. So, and when we look back, here's the sinus of Valsalva, diameter of the sinus of Valsalva, and also the ST junction. We can find that they are so generous. All of them over 30 millimeter, and the height of the sinus of Valsalva is 13 millimeter, and the height of the ST junction is 23 millimeter. So when we check the RCA height to the upper edge of the ostium, that's around the 18.6 over 13.1 millimeter, and the left coronary artery height is 16.9 and over 11.3 millimeter. So, and also the depth of the membrane septum is around 2 millimeter. So we simulated this patient with the Evolut FX 23 millimeter valve and the SAPIEN 3 23 millimeter valve. But so when we move to our strategies from our heart team, at that time we also, for this patient, we have the Sentinel cerebral embolic protection device. And for this patient, at that time we decide to have the pre-dilatation with the Atlas golden balloon, and the plan to have the post-dilatation with also have the Atlas gold balloon. And at that time, we plan to decide to put the Evolut FX 26 millimeter a little bit larger than what we calculated from the MSCT. So here is the result. From the left side, you can see that we pre-dilated with the Atlas gold balloon, and then for precising, and then we implant the Evolut FX 26 millimeter. And then after that, echocardiographer reported that there was a paravalvular leakage at the 2 o'clock position. So we did the post-dilatation with the Atlas gold balloon again, and the final result is quite well. So you can see that's a minimal pressure gradient. Thank you.
It's a pressure.
Because we fracture, so we can upsize. Yeah, that's why we intend to do fracture beforehand instead of after. 22.
The first is a 20, and 20 hard to say we break that. After that, we because of because you know that 26 is too large for 21 epic, so that's we decide to post-dilate again and fracture that.
Okay, so you did fracture.
Yeah. Yes, so that's
it looks well expanded.
Yeah, so that's after fracture, everything is perfect. It's the residual pressure is around 5. So that's before fracturing, we also check the pressure quality.
It looks underexpanded.
Yeah.
Dr. Hong, do you have an image for the fracturing? I think we have the image during the balloon fracturing. You can see the bottom one. Yeah, you can see the rough frame fracture.
Did you capture any debris in the protection? At the end, did you see any debris?
For this case, we did not capture anything. Didn't capture anything because every procedure we do the.
Yeah, it looks. The good thing is that with this case, if this valve ever fails, you can still put another valve in there. You can put a 23 S3 now.
So I
you
think
won't have
that the third valve is. Oh, sorry.
That's a lot of goodies.
You say nothing. It's a surprise to me. I say, nothing. That's.
Well, you as researchers will say, yeah, we didn't see anything. It was right in the operating room. We always say no. You denied.
That's why I'm so surprised that nothing captured.
I mean, that would be difficult. Yeah, great case.
Actually, what kind of material? That's interesting to see.
Debris, right? Debris, yeah.
So I think it's infected tissue. I'm pretty sure it's from infection. If you get the debris of the leaflets, that's usually infected because usually don't.
Friable.
Yeah, friable tissue. So I think it's infected tissue.
Okay, great.
Next,
please.
Yeah.
Good afternoon to participant expert and the audience. The next case is a CT workshop for the mitral valve case. Our patient is a 67 years old man who suffered from dyspnea insertion for several months. He has previous diagnosed with severe mitral regurgitation, moderate aortic stenosis and regurgitation, and underwent surgical aortic valve replacement and mitral valve replacement in 2024. However, at that time, he also diagnosed with aortic valve, paravalvular leak, and hemolysis under redo operation in the same admission. So this time, he was diagnosed with mitral bioprocesses failure with severe valvular regurgitation. His comorbidity, including atrial fibrillation, coronary artery disease, which is single vessel disease, and hyperlipidemia. His SCS score is 8.1%, and the CAS relativity score is 0 out of 6. His hematocrit is 35, and the creatinine is in normal range. So this is the pre-procedure echocardiography. As you can see, the LV ejection fraction is in normal range, which is 58%. There's also concomitant moderate tricuspid regurgitation, which RBSP is 41 millimeter mercury. So through the TE imaging, we can see there's a failed bioprosthetic valve leaflet, which causing a severe valvular mitral regurgitation. So this is our patient's condition, and so
very short CT. So the area is 374 next, and 12 short neo LVOT. Twenty-three. 26. 26. Yeah, so for the two questions, if we put in 26 and more ventricle, it seems to look like smaller. And if we just use the APP because it's ID is 23, so that we just use the 23. Or we break that and use a larger valve, 26. It's a mosaic. The mosaic depends on when the valve is made. I think after 2018, you cannot fracture it because they changed the construct of the thing. But unfortunately, you have no way to tell. Yeah. 2014. Yeah, 2014. So maybe you're lucky. So you can fracture, because some people have described, oh, you can fracture, but actually after a certain time, you cannot fracture. But I would try to do 26 and fracture if you think it's safe, because otherwise I think you might reach mitral PPM. Especially, I don't know how big the patient is. We've had this issue. 23 mitral valve is small, right? It's a small valve. For everybody, 23 too small. Yeah. I mean, unless you have no choice, small female, you worry about. I mean, also, yeah. So a mosaic is porcine. Again, your neo LVOT is going to be better than you measure at the commissure. So. How about you, Ika?
I agree. I think the porcine is unlikely to be, when it's short, it's kind of thinner and short. And also this patient is mitral regurg predominantly, not stenosis as well. So I think it'll be fine. So
the other problem is pre-break or post-break. I have all no idea.
I always do the post break, so that's that's my approach. And because I had a crash with the pre fracture, so
you have a MR already as a mechanism, so you might be okay. But you just worry about a kind of flail leaflet that could risk embolizing, tearing the leaflet more because it's porcine, right?
Yeah, I agree. This one I have a severe MR, so probably won't crash, but. Another thing is I just wondering whether you put the valve in, so, a post-dilatation, less chance to have an embolic event compared to the pre, because that's a direct interaction with the balloon. This at least there's a stent to protect some. You know, I'm not sure, but I usually do the post.
Yeah. From my my observation, if we do the BVF for the LT valve, and if cause severe AR, the hemodynamic collapse very quickly. But if you do the BVF for the mitral valve or do the LAMPOON procedure and causing the severe MR, patient may tolerate it better. So if do the BVF and causing the severe MR, I think the patient can tolerate it more. Yeah.
I heard a China team that they break some cases and then the patient die after when the patient returned to ICU. It's happened in United States, or the United States break the mitral valve without any problem.
I mean, they don't tell you, right? no one shows their the cases. They don't make it. No, but absolutely, there is a risk of AV groove, injury. That's absolutely true. I mean, just like aortic root injury, you don't hear about it, but can absolutely happen. A delay, particularly if the blood pressure is not controlled, right? That can definitely be a risk.
We talk about
it's a muscular injury. Sometimes the strut, right, when you fracture, can go into the mid ventricular cavity, and if not careful, like in surgery, right, you can see small females, hyperdynamic ventricles. I mean, this one, that the ventricle looks okay, but you can imagine some of those MS ventricle may be a potential risk if you're very aggressive.
Yeah, yesterday we have the speaker talk about the broken mitral, and I did not break the valve often, and Professor Ye said that you must take care of the circ. So in this picture, you can see the circumference over there.
Yes. Yeah, I think it looks like on the other view, not in this view, on the mitral view, you go back to the mitral tab interface, it looks pretty far away. Yeah, you can go, see, you can see the circumflex there. You can go up and down. Now this is mosaic, so you only measure the internal diameter, but you have to go up and down to see whether circumflex crosses. It looks like it's kind of far away. But sometimes it's not the circumflex that you worry about. You rarely kink the circumflex, but we did a valve in MAC where one of the MAC had a contained AV injury and pseudoaneurysm afterwards. So that is a risk. I mean, people don't talk about it because also mitral valve involved, the fracture is not commonly done, right?
So next time is in the mitral valve procedure, we should check the circumference also. It's what you mean, because we never check the circumference position for this picture.
I guess depend on your initial suture placement. Is because if you place per suture placement a little bit high in the atrial side, you could point down close to the annulus, or the valve is enlarged, like bigger size you put it in, and that could be a push too close to the circumference. That's a possibility. But the question is, this one is you from a 20 internal diameter, about 20 to 26. That's a 26, right? You put 26. That's a huge fracture.
4 millimeter difference.
Yeah, that's I would be a little concerned to do this kind of large fracture initially. Immediately to the 26, so I'm more conservative. Will fracture to the some step, and then we'll see how the gradient. If gradients are accepted, I will probably leave it. But if gradient is still high, I may do a second. But I'm probably more conservative.
Your point about the circumflex injury, if the patient has existing MAC, and you have a valve replacement, so be careful for fracturing that, because the MAC may push out to the circumflex. I think that could be a potential risk.
So the circumference with MAC is not implies not safe.
Remember, valve in MAC has never been done until last 5-6 years ago. All the surgeons have to do it conventionally, right? No choice. So those prosthetic valve will fail, right, and come back patient on dialysis or someone. So you have to see where the MAC is relative to the circumflex. If you very aggressively fracture, you could injure something.
Yeah, the other thing is the per se you need to check a lot of the puncture site. And how do you decide the puncture site, or just see the echocardiography and puncture the septum?
Transeptal usually is posterior, but you don't have to be so high, much height. You have to at least 3.5, just to accommodate sapien 3. Now, if you plan a fracture, you make sure the balloon goes, into the ventricular side to make sure you clear But other than that, we don't usually use the CT to look for transeptal. I mean, they do that for the native TMVR, I think because of the device are very bulky and big to be able to have enough room to steer down, but the sapien is usually not an issue. Yeah.
So that's in the app, they say that the puncture site and the simulation that we do not care about that, just see the echocardiography in the scene.
Yeah, most people we know. Sometimes you can even use fluoro. The rule of thumb is you go transeptal RAO view, you go at least at the bottom half of the surgical valve to puncture. You don't want to puncture superior. You want to puncture more inferior because otherwise you cannot rail in the trajectory. So that's where, you know, the CT may be helpful, but also you can use fluoroscopy to help you.
Yeah, because every time that's the report sent it to me, there's a lot of puncture hole over there, and you should do at the 2 centimeter and which angle to. However, I got confused, and every time I do the puncture, it's just depend on the echo and the distance measured by echo. So there's in this the clinical support should not check this because every implanter just check it from the echo. So please go on the implantation.
Yeah, it's okay. So our case is a 27 millimeter mosaic porcine valve. Its internal diameter, internal diameter is 22. So in this case, on the consideration of the patient prosthetic mismatch, we will decide to perform the biprosthetic valve fracture with 26 SLS gold balloon, and we'll choose a 26 millimeter sapien 3 valve for this patient. So in our center, the left side heart disease, we all use the Sentinel cerebral and body protection device. So this is the transeptal puncture, with the TE guidance. Then we use a 12 millimeter balloon for the septostomy, because this is only a 26 millimeter sapien 3, so we don't use the 14 millimeter balloon. Okay, so this is the critical point of our procedure. We use the 26 atlas gold for the biprosthetic valve fracture. So there's an audible click around the 18 to 19 atmosphere for this patient with a rapid drop of the pressure of the inflator. So I think the biprosthetic valve fracture has completely done successfully in this patient. So next we deploy the 26 sapien 3 with 2 cc overfill. And we also post dilatation with the same volume. So this is our final result. As you can see, the mean transmitral valve gradient is only 3 millimeter mercury, and the valve is expansion well under the 3D LA and fast view. And there's only minimal valvular regurgitation residual.
So that next time we will do that's add more worry for this case. Because the after break is you can open in any other direction.
The peak gradient is only 8 because it's atrial fibrillation in this patient. As you can see, the PW of the Doppler, you can see is variation a lot, but the peak gradient is only 8. The mean grade is only 3 to 4.
So that's it's 26 is okay for this case.
Yeah, I think so. It looks great.
The other problem is me is do we need more balloon because we break that and
no, you already post dilate the same and looks you have a little bit of a waste, but not
because
much.
In this case we add 2 cc more.
Yeah, no, we always add volume anyway because it's recoil, so it doesn't really make a difference. Your case is a rigid structure. It's not a native structure that you worry about, you know, rupturing. So, yeah, that's just more like a touch-up to make sure you flare the outflow very well. It looks like a good position. Look at the. Sometimes you have to be careful about the stent frame interacting with the septum. For native, valve in back, you have to be very careful. You can push the valve more atrial over time. With this, you oversize, your fracture should be fine. But Vinayak has shown some pictures where looks good the first month, and then 6 months later, the valve is halfway into the atrium because of the lack of oversizing. But valve in back, you have to be very careful about the septal contact. So
because of time, we must close the section and today's program. I think, thank you. In the future, maybe we have time, we have the CT workshop again, and hope you join this, and hope you genius guy that teach us how to do that.
And for participating in this meeting. This meeting, we have 11 live demonstrations, including 5 cases at Chengchi General Hospital and the 6 live cases in China. And our participants from 18 countries, including Canada, United States, Korea, Japan, Thailand, Singapore, Malaysia, and Vietnam. We have 80 speakers, many panelists, and we have also many moderators. And this time, up to now, we have 20,000 person time visit on the line. So I think this is a very successful meeting, and I hope everybody can gain a lot from this meeting. We know that the treatment for the heart valve disease is booming, and a lot of inventions and a lot of innovations. So it is very, very good for all the patients in the future. Next year, we still will have a Taipei Valve Summit from the June 6 to 8. So please reserve this time for next meeting. So thank you again for your participation, and hope you have a very good time and also healthy and also very happy life. Thank you again.
As Professor Wei already mentioned, this is a very successful meeting, and with 20,000 patient visit, it's very surprised to me. I was shocked that yesterday that mentioned to me about the number. I said, "Wow, that's unbelievable," and also I surprised with 80 speakers. Wow. That's 2.5 days, 80 speakers. I think it's a very, very I think a very excellent meeting and a very successful meeting. I think very practical and also educational, all the program. So I just want to say the thanks Zhengxin's team, Dr. Wei, Dr. Yin, and all other team, their team member for the really like hardest several months work to organize this excellent, exceptional program. I really appreciate it. Thank you for the Zhengxin's all team member for the great work. And also, I like thanks to all the staff behind the scene. They work so hard to ensure this meeting went so smoothly. Without all these people behind the walls and or outside the room, I don't think this meeting went so well. So I really appreciate for their hard work for all 3 days. And also I'd like to say thanks to the sponsors for their support. And all the best. I hope to see you all next year. Thanks.